the board, and I'm very keen to get started and to get everybody involved in the discussions today. So first of all, can I take any declarations of interest? Other than those already previously listed? None? Okay, thank you. Apologies for absence. I understand we have both apologies from Neil and also from Manjeet, unfortunately today. Any other apologies, Shirley?
Not that I'm aware of, Claire.
Okay. On to the minutes of the last meeting then. We agreed that those are our true record. If we move on, are there any matters arising from that? And then on to the action log.
So on the action log, Claire, all the two actions that are due are green, and the details on there and all the other actions are due later in the year. Okay,
thank you very much for that. The chair's report I'll take as read. So far I've had a great opportunity to get out and about and visit different parts of the ward, and also to get to Newark. And yesterday I was really pleased to take part in going round with Julie and Richard celebrating the International Midwives Day. So it's really good to see so much activity starting around the trust, and different people coming back on to site as well. So nice to see people. Okay, are there any questions on the chair's report? No, then I'll move over to you, Richard, for Chief Executive's report.
Good morning, everyone. Lovely to see you all. I hope you're all safe and well. So, Claire, welcome. As you described, this is your first formal board as the chair. Thank you for your personal support over the last couple of weeks. I look forward to working with you over the coming year. And Andy, lovely to see you back around the board table in your new role. So just a few things from me. Pick up as we have for the last probably 14, 15 months on COVID. Things are clearly improving both within our organisation and across the community. We have low rates of COVID in the organisation, and the workforce absence has returned to pre-COVID levels. We'll hear an update in a moment from Claire Teeny. We're making lots of progress around our vaccination programme. I think just under 90% of colleagues being vaccinated, and good uptake across all of our staff groups. It's really impressive, and I think we're now seeing slightly less than 80,000 people being vaccinated at Kingsmill Hospital, which is part of the Nottinghamshire, then the regional, then the national vaccination programme, which is also excellent. We reported a couple of boards ago that Kingsmill had been identified as one of the top 5 performing hospital hubs in the country for vaccination, which is great. So thank you to Claire and everyone involved in that. In terms, I've touched on, we've got our workforce absence rate is a lot lower than it's been. That indicates that lots of people are returning to work, which is probably a good thing. It's also clear that our car parks are busier than they've been at any stage over the last 15 months. We've had a number of conversations at the exec team and the senior leadership team over the last few weeks. I think it's not unsurprising, but I think we've probably failed in our efforts to maintain flexible working across our workforce across the organisation. And I think we need to review this, and Lorna's taking the lead on sort of checking our communication around this. We had a clear framework in place over the last 12 months about flexible working on an individual basis, for all of the obvious reasons, working with people to ensure that they had conversations with their line manager. And I don't think it's surprising, as I said, but we now have far more people back to on-site working than we had at any stage over the last 15 months. That obviously brings a risk, and we need to all ensure that we maintain social distancing, that we wear face masks, we maintain hand sanitisation. I'm also aware that as people return to more time on site or people returning to work for the first time in 12 months, that may bring an understandable level of nervousness and anxiety, and I'm sure we can all support people around their return to work in a safe way. Restoration of services, Simon will be updating on that later as we look at the SOF. I think the restoration of services, whilst providing longer term support to our colleagues, is difficult, but I don't think it's impossible, and I think we are as well placed as any organisation in the country to do that effectively. Helen Henley, the Deputy Chief Operating Officer, has written a blog which will be in the NHS Providers next Thursday about the way in which we can focus on restoring services whilst supporting our colleagues. It's been nationally reported over the last couple of days that the NHS is looking at an elective recovery accelerator programme, and funding announcements about that at a system level will be made next week. Clearly, we will focus on our SOF, and we've had a series of conversations at execs about some of the quality metrics, the safety metrics and the patient experience metrics, and Julie and Dave will talk us through those. And the other bit I think we need to touch on from a SOF perspective is we've had in 2021 a slightly easier year from a financial perspective, because as we know, in the first half of the year, well, actually for the entirety of the year, some of the mechanisms around financial governance changed. I think that means that for 21-22, finances are going to be more challenging. As we've touched on before, in public board, the finances of Sherwood are intrinsically tied into the wider system finances, but I think it's really important in Sherwood we are able to evidence, as we've done for 5 consecutive years, very strong financial governance and delivery of meaningful financial improvement plans, which involves us reducing our cost base in the organisation. On to wider strategy. We had what I thought was a really interesting and useful board-to-board session with Notts Healthcare on the 20th of April. We have a strong relationship with Notts Healthcare, which we're keen to explore further, and Paul Robinson is taking the lead on that work, and some of the specific deliverables will be coming out in the next week or so. And then Claire, Graham, Dave and myself met with Chief Execs Chairs, one Ned and MD from Nottingham University Hospitals and Notts Healthcare yesterday for sort of a 3-way strategic conversation. What I took from that is clear that our organisations are already closely aligned. We do have many opportunities to work more effectively together as 3 organisations to improve our patient services. I'm still not entirely certain why we're not pursuing all of those options, but we will look to explore them. And I think it's important to recognise that it is perfectly possible and acceptable that each organisation will have multiple strong collaborative relationships with other healthcare and third sector organisations. Claire and I have been talking in the last week, and we are going to take the opportunity, the next board workshop or the one after that, to explore the strategic options that are available for Sherwood. I think that will in learning from other organisations of a similar size to us across the NHS, and also reviewing the people that we will need to be influencing and taking with us to shape some of those decisions. I think my reflection on some of the conversations I've been having over the last couple of weeks is actually Sherwood is in a really strong position to influence and to shape our future, and possibly we are more influential than maybe I had given the organisation and possibly myself credit for. I also think, and we'll touch on the Mid-Notts Integrated Care Partnership in a moment, I do want to be clear that the executive team and I are sort of occupying 3 levels of focus at the moment. I've referenced before the day-to-day running of Sherwood is extremely difficult. Increasingly, the integrated care system is taking up a huge amount of our time, especially from the restoration of services perspective and a single financial plan, single capital plan, etc. And actually, it's the Mid-Notts ICP focus that has been squeezed out because we only have a limited amount of time to spend on that. So we do need to work out, as part of that wider strategic conversation, where do we want to take the work across Mid-Nots. So to conclude, I wasn't at the last board in April, but if I had been there, I would have reflected on the last 12 months. We know that we've got a clean bill of health from the CQC. In March 2021, we received the prestigious Health Service Journal Acute or Specialist Trust of the Year. For the third year in a row, staff engagement at Sherwood is the best in the Midlands, second in the country for morale. We're going to touch on maternity services in a moment, but we are buddying with Shrewsbury and Telford NHS Trust, a work of national importance, and gives us an opportunity to reflect on our services. We are working effectively with a range of partners. In the last year, COVID has fundamentally changed our working lives and our personal lives, but we've responded well. And I think we have been, there's always more to do, but I think we've been exceptionally strong the way in which we've been able to support colleagues. I think we have more autonomy than most, and as I've referenced, probably more autonomy than sometimes I perceive us to have, and we have a strong national reputation. So there are lots of reasons to feel positive and optimistic. It's clear that the next year is going to be tough. We have to restore our services. We need to look at colleague welfare and well-being, and we know that the trauma experienced over the last 12 months will manifest itself in many different ways over a longer period of time. And as I've referenced, we have got, like the wider NHS, we will have increasingly stringent financial pressures. But I do think, recognising that balance, we have a great opportunity, certainly in the first half of the year, to shape the strategy at Sherwood and the strategy across mid-Nottinghamshire, both from a health and a care perspective, in a way that puts us in a really strong position for at least the next decade. So I will pause there and very happy to answer any questions.
Thank you, Richard. And I think that's a very good example of the confidence and growth of both yourself and Sherwood, that we are able to think about our place in the system and what we're going to do in the future, and the relationships that we have with other organisations. And I'm very confident that the discussions that we've had, both with NUH, with Notts Healthcare, will allow us to provide better services to our patients across Nottinghamshire. So can I ask if we have any questions or comments on Richard's report? No, I don't see any hands. Perhaps, Richard, I can just ask you about Newark. Obviously, we started to bring back additional services there. What sort of feedback are you getting from staff about the opportunity to do more at Newark than they've been able to do for some years now?
So Newark is one of our 3 important hospital sites. In many respects, we've been able to protect it from some of the most challenging aspects of COVID over the last 12 months. Myself and a number of execs now are visiting Newark with the level of frequency that we were doing pre-COVID. It sort of dropped off inevitably during the COVID perspective. We know that in the last 12 months we've restored orthopaedic services to Newark for the first time, I think, since 2012 or 2013. Newark has huge opportunity to become a thriving elective hub. We continue to work with our commissioners and other organisations to identify the services that would be best placed at Newark. We were getting to the position pre-COVID when actually, from many respects, Newark was full in terms of Monday to Friday, 9 to 5 operating and outpatients. So there may well be some services that we would look to move into the community to bring other specific services in. So yeah, it's an important site for us. We have got more services there than we had 6 months ago. It was doing really well pre-COVID, and I think we can move beyond the levels of activity we saw this time last year fairly quickly. I will also say, Simon, if there's anything you want to add to that.
No, I haven't got anything to add to that, Richard. Obviously, we've moved elective orthopaedics over to Newark, so that's a big piece of work, and there's ambition to extend more operating. Newark has been what we would define as a green site during COVID, and has kept a lot of operating going. So I think colleagues there have done some great work. But obviously, we've got to make sure that we manage the risk in terms of Newark being an isolated site as well within that. So there's a balance to be achieved there, but we're certainly doing more elective work than ever there at the moment.
That's great. Thank you very much. I don't see any questions in the comment box, so perhaps we can move on now to Claire Teeney. Claire's going to report on the COVID vaccinations update.
Good morning everybody. Claire Teeney, Director of People. The report is here for assurance, and as Richard touched on earlier, the vaccination programme goes from strength to strength really. Through the hospital hub, we have vaccinated over 80,000 people, which is a phenomenal number. And in terms of our colleagues at Sherwood, we've vaccinated 89% of those. And for the small number that are remaining, we are working with individuals to support them through the vaccination process, answer any queries that they may have. So that's all being worked through really well. I think a couple of other things just to mention are that from a Sherwood perspective, we've been running the hospital hub, but we've also hosted the flexible workforce to support the wider vaccination programme across Nottinghamshire. We've onboarded over 4,000 colleagues to date now, and those colleagues work across 9 sites. And the plans are now in place for how we take that resource hub to support life beyond a vaccination programme, and how we utilise that flexible workforce approach to be able to deploy people flexibly across health and care across the system. And we're working at a regional level to take that concept forward. So I think that's really exciting for us to be in that space, and is a really good reflection on the work that the team have done, because it provides a good level of confidence that actually we can deliver on that. System-wide, there are over 500,000 first doses of vaccination that have been delivered, and 182,000 second doses. So overall, that programme is working well, and we're on target in terms of being able to deliver against the cohorts, which are now open to over 40s. So the whole programme, as I say, goes from strength to strength, and I think it's something that we can be proud of from a Sherwood perspective, and also in terms of our collaborative working across the wider system. The month of May brings for us onward planning. I talked a little bit there about the flexible resourcing team and what we're going to do in terms of the workforce, but also the plans are now in place for what COVID vaccinations may look like come the autumn, along with flu vaccinations. So system level planning starts on that this month. I'll pause there, Claire, in case there are any questions.
Thanks, Claire. We've got a question from Barbara.
Morning, thanks Claire. Really fabulous results in terms of coverage from the vaccination programme. It's really excellent. Obviously, be very keen to see even more than the circa 90% that we've got now. I'm just curious to know what discussions, if any, have been had about making the COVID vaccination compulsory in the same way that hepatitis B is for healthcare workers.
Yeah, and thanks, Barbara. So those conversations are ongoing. At the minute, the vaccine isn't mandated, but things are being looked at, particularly for certain settings. And actually, there is more of a focus on care home staff than wider healthcare workers at this point in time. No final decisions have been made, but as I say, it is an ongoing conversation that is taking place. I think the at the minute, the message remains about encouraging colleagues to have the vaccination. And I think that certainly from our perspective, what we can take a level of assurance from is that a number of colleagues stepped forward early to receive the vaccination, more so than we've experienced in some previous years with flu. So I think that that was useful in terms of a sense of a behavioural change and being on receive. But yeah, I'll keep the board posted in terms of where those conversations get to, but nothing's changed in terms of the approach to date.
Okay. Chair, would you mind if I asked a follow-up question? It's just a second question. Claire, I was interested to see the workforce summary at the back of the report, and it looked like we've got a fill rate at the Trust of about 66%. So compared to what we need, we're running at about 66%, if my understanding is correct, and we've seen a downward trend. So I noted you were saying about plans for workforce going forward as the vaccination programme. I'm just curious that we're able to run a programme at the moment at 66%. Is that not creating lots of challenges?
Yeah, it's not actually, Barbara, because I think actually some of the rota requirements compared to what has been set out to what's actually then being needed in practice have levelled off. So so I think it's more a recalibration of rota requirements. So when we started delivering the vaccination, if I take Christmas Eve, we were on circa 300 vaccines that were being delivered. We can now deliver over 1,000 a day through the same hub, because A, the staff have got used to it, B, we've got a different type of vaccine, and C, we can run the processes much more fluidly. So I think it's more about a recalibration of rota requirements against fill rates. So we haven't experienced any challenges really overall, either at the hospital hub or across the wider system. Everything's been able to be delivered. So I think we've got high confidence around that. It's more the onward planning as to what we do with this excellent group of staff.
Yeah, thank you. Thanks.
Thank you, Claire. I don't see any other questions. So, Richard, did you want to come back in? Yeah. Yeah.
Apologies. Just sort of picking up on Barbara's question about mandating and Claire Tierney's response. I think as Claire Tierney was describing, getting to the best part of 90% is really strong and certainly compares well to the regional and the national position. In general, the reason why it's not at 100% at the moment is because individuals feel anxious or nervous about being vaccinated. And I strongly think that if it was to be mandated at the moment, all that would do is increase the anxiety and the nervousness for those individuals. So whilst the national conversations will continue to play about mandating, I think the key role that we have as an organisation, and it's working really effectively as evidenced by the high uptake, is having those individual personal conversations with people, in particular clinically led, so that they can explore why they may feel nervous about having the vaccine, and we can provide them with evidence that it's safe. So I think that's the route for now that we need to continue at Sherwood.
Okay, thank you, Richard. Moving on to strategic objectives, we're being joined by Richard Mills, I think.
Good morning, yeah, I'm here.
Hello, Richard.
Can you hear me?
Yes.
Apologies for hanging in the background. Morning, everyone. Hope everyone's well. Yeah, so this is the strategic objectives update paper, providing a final update for the 2021 progress against the 15 strategic objectives. So the layout of the paper's similar to previous updates that you'll have seen, provides an overview of the actions that have been taken against each of them and a brief summary of the impacts and outcomes for each objective. So I think overall the updates reflect a good deal of progress really over the past year. Some of the outcomes will have a really positive impact on patients and colleagues over the coming months as well as over the past year. So some kind of examples of that around the successful recruitment and retention under objective 3.1, with overall vacancy levels lower than they were in 2019-20. 5.2, we've also been the lead workforce provider for the COVID vaccination programme across Nottinghamshire, and 5.3, the update about the SFH Green Plan for 21 to 26, which I understand was approved by the board last month as well. So some really positive updates there, I think.
Excellent. Thank you very much, Richard. I don't see any questions at the moment in the chat box. Just on the green plan, Richard, what's the timetable now for getting our sustainability manager?
So I don't know the answer to that, actually, Claire. I don't know the specifics of the timetable for that. I'm not sure if any of my executive colleagues know, but if not, I'll follow that up with Ben to find out.
Okay, that's
Apologies.
great. No problem. That's all right. I don't think we've got any other questions for you, Richard. I think that's happy to approve. Barbara.
Hi, Richard. It was really, thanks for the report. Just thinking about looking forward in terms of plans for the year ahead, really.
Yeah.
Where we are with that.
Yeah, so the 2021-22 objectives are currently under development, and will be in line with our planning submission, which is going in today. So I know that Emma Challens met with clinical chairs last week, talking through priority themes and talking about how we might turn those into kind of smart actions. I think Emma, I don't know if you wanted to update on that.
Yes, thank you, Rich. So we've developed a set of themes that are very much focused around the next 12 months in terms of recovery, restoration, and the planning guidance. Equally, in terms of what we believe are key priorities at a system level. So Rich is right. We've had conversations across our executive team, with corporate teams, met with clinical chairs. And then we're following that up with division general managers as well later this week. The intent is that we come back next week with an outline of specific actions for 21-22, which would then be our breakthrough objective. So the answer is we've been working those up together the last 4 to 6 weeks, really. And some of that was underpinned by awaiting on some of the planning guidance. So we will have them coming back to execs next week. Thank you.
Right.
Thank you.
Thank you very much, Richard. And we've also had a comment from Graham just thanking you as well, and noting that this gives a very good progress report really on what's been happening over the last 12 months. So thank you very much for your report, Richard. Andy, I can't see whether Andy. Right. I've got Andy's just updating about the National Clerical Fellow Scheme for Sustainability was opened last week. So we don't know at the moment if we've got any candidates, but hopefully we will have an update on that in due course. Dave.
I was just going to add that I've circulated that widely. Great.
Excellent. Thank you very much for that, Dave. Okay, perhaps we can move on now to strategic priority 1. Julie, if I can ask you to give us the maternity update.
Thank you very much. Morning, everybody. So just a few highlights from me. So obstetric hemorrhage, you'll see that actually we are back into the green this month, which is the first time for some months. The team continue to review every major obstetric hemorrhage to identify lapses in care, and there have been no recurrent themes identified to date. Stillbirth, for the last report, the Q3 figure was elevated, and in Q4 it remains above the threshold but has come down a little bit. We reviewed this as part of the Safety Champions meeting yesterday. The only clear area that we need to focus on is deprivation. So there wasn't an increased proportion of these within women from Black and ethnic minority populations, or even those that were smokers, to be honest. The only thing that stands out is around deprivation, and we have our continuity of carer teams focused in those areas. We are going to just do a quick observation of postcodes to just make sure that we have got them placed in the right areas. The other thing to say with that is that with the Saving Babies Life Care Bundle, there is a scanning protocol that was rolled back as a result of COVID based on guidance from the Royal College of Obstetricians and Gynecologists. We are now putting the full protocol back in place, and that should take effect in the next couple of weeks. So we're hopeful that that will help us bring that stillbirth rate down further, but we continue to look at every stillbirth that we have to ensure that there aren't lapses in care. At the moment, the only thing we found is the deprivation. From a staffing perspective, and you'll see this later in some of the other reports, we've really struggled with staffing in Q4, and midwifery has seen a similar picture. So the midwife to birth ratio was 1:30 rather than our plan of 1:28. The team have mitigated that well and managed to move staff around the unit. So we've not had any incidents of harm as a result of that, but I think it's fair to say it's been quite stressful for everybody over the last quarter. Incident reporting remains stable and all of the incidents were of low or no harm. There's nothing in there of concern. They are the usual reportable incidents that you see each month. We continue to make good progress with the NHS resolution programme and the Ockenden recommendations, and there's a maternity assurance committee that has been set up and will meet for the first time on Friday, that is exec led, and will provide an update to the quality committee around our assurance with the safety actions and the Ockenden recommendations. Just want to highlight the excellent progress that teams have made with mandatory training despite what's been going on in the last quarter of the year. So they've made really significant progress with this, and we were given commendation nationally for our progress with the CTG training. So that's a really, it's really good work by the team there. And we continue to make continued progress with the friends and family tests for the first time in the last 6 months, the recommendation rate is above 90%, and that is attributable to the increased response rates that we're getting. Happy to take any questions.
Thank you, Julie, and I think that is really good to see the friends and family test reporting, both in terms of the rate of feedback but also the results that we're getting, is testament to some fantastic work going on in our birthing unit. Okay, do we have any questions for Julie? No, I don't think we've got any questions there at the moment for Julie, so thank you very much for an excellent report.
Thank you.
Okay, so we're moving on now to strategic priority 3, to maximise the potential of our workforce. So can I hand over now to Emma, please?
Thank you, Chair. So provided within the papers, and shall take as read, is an update with regards our 2020 staff survey results, and also supporting that paper is our actions for improvement over the next 12 months. There's just 2 to 3 things I'd like to recognise. One, I think it's first of all that we're incredibly proud as an organisation, and hopefully our colleagues are, in our staff survey results for 2020. I think it's a real demonstration of the unity and the teamwork and our culture across the whole of Sherwood Forest Hospitals, and particularly around certain areas where we've seen some significant improvements in overall Sherwood being a great place to receive care and to work. So I think first of all, it's just recognising how incredibly proud we are of colleagues across the organisation. You will recognise that we are again, for a 3rd year running, the best trust in the Midlands, and also this year again extremely proud that we're rated 3rd in the country out of 128 acute and community trusts. And that just shows, I think, the continuous improvement for us as an organisation, and will hopefully continue to attract talent to the organisation as well. There's 3 really key indicators in the staff survey. One is about being a place to work. One is also about, would you want your family and friends to receive care in our organisation and across our sites? And the third one being, do we place patients as a top priority across all of our sites and services? And again, compared to last year, our results for 2020 have significantly improved in all three of those, by about 6% increase in every one of them. And again, I think that just demonstrates about how we pull together as a team and how we work across the whole of the organisation in providing high quality care. But, you know, there's always things that we can do to improve, and hopefully the paper provides assurance on those areas that we need to continue to pay attention to over the next 12 months. And those are outlined and are more prescriptive in the attached action plan, where we've detailed what we will actually do over the next 12 months by continuing to work together to continually improve as an organisation. And for example, some of those key areas are relating to continuing to support colleagues from a health, welfare and wellbeing perspective. We're very confident and of our services that we currently offer, but also very mindful of what the psychological, physical impact is on colleagues, and that actually we need to ensure that we continue to have a robust offer in a timely, rapid manner. There's also, with regards, a very key area around violence and aggression, and particularly with reducing the experience of violence and aggressions felt by our colleagues. And this is an area that our chief nurse is particularly leading on around the violence prevention and reduction policy, and also we're supporting in terms of cultural interventions around improving experience of civility and respect in the organisation. So there's some real key focus areas for us, and hopefully you'll be assured that we've identified those from our results, and we will continually improve and learn together as an organisation. So I'll pause there and I'll take any questions. Thank you.
Thanks, Emma. Before I move over to Richard, can I just ask a question? I noticed that it states that those under 21 and over the age of 66 are continuing to have a poorer experience at work. Do we know why that is, and what are we doing to tackle that?
Yes, of course. So we're actually doing some more exploratory sessions with our workforce that are under 21 and over 65 to understand greater level of detail as to why. Is it around career opportunities? Is it around feeling supported, developed, whether they're coming in as apprentices or other? So where we have got particular areas over the next 2 months, we're doing some focus group sessions, particularly relating to that specific one, Chair. And then that way we'll be able to provide some bespoke support development across our workforce.
Okay, thank you. Richard.
Thank you. So lots of positive stuff there, as you said, Emma. You also understandably drew attention to the theme of violence, which for a number of years has been really poor. And I think when we see our position within the region and nationally, I think it's actually a position of sort of embarrassment for Sherwood. So a couple of questions. Do we know why we score so poorly against that violence as a theme, number one? We're in May, so whilst we didn't get the results until a couple of months ago, we're 7 months after the collection of these results. Can we be clear about what we've done to improve the perception of violence at Sherwood over the last 7 months? And then we've got circa 4 months before we capture this information again. So specifically, are there things we're going to be doing in the next 4 months to build on what we would hope would be progress over the first half of the year? Thank you.
Yeah, thank you, Richard. So I'll start, and then I see Julie's coming, who's particularly leading a lot of this agenda. But first of all, just to say that we started some focused work within this area and probably at the end of Q3 and Q4 last year. And what we have seen in the 2020 results is some slight improvements in terms of experience and also reporting of, which is another key area where we need to improve in terms of we can learn more, we can understand more, and therefore we can take action. So we have seen some very slight improvements of the 2020 results compared to 2019. And I'll hand over to Julie, who can update in terms of specific things that we have done and are in train over the next 4 to 6 months in terms of improving that position.
Thanks, Emma. So we've done a deep dive of the incidence of violence and aggression to look at the types of patients that are actually displaying these behaviours. So there are 3 big groups. The first one is a cohort of patients that have got dementia and delirium, so don't have capacity to understand their actions. The second cohort is along the emergency pathway, where we have patients who are intoxicated with alcohol or drugs. And the third cohort is a cohort of mental health patients, again on that emergency pathway. We have commissioned an external risk assessment, which was conducted by Eric Baskind, who is a national leader in reducing violence and minimising the use of restraint. And he's given us a series of recommendations that the executive team are overseeing, and we're making good progress with implementing those recommendations. They are around training staff in de-escalation and restraint techniques, fundamentals of security and appropriate resourcing. And then the second big piece of work we are doing is around the NHS improvement, reducing violence and aggression standards. We are working to draft standards, but they have been formalised this year, and we're making good progress with those as well. And again, the executive team have oversight of our progress with them meeting those standards. We have had significant investment in this area. So we have invested in a significant amount of training around reducing, minimising the use of restraint. We've also invested in some trainers to provide that restraint and to have oversight of every episode of violence and aggression that we have, so that we have a senior, they're called PMVA, so prevention and management of violence and aggression. So they are experts in that field that will review every incident and be on hand to support staff around the clock should those escalating behaviours happen. We've also done a series of communications around learning from restraint, because restraint is the very end part of this, and we need to try and manage these behaviours much earlier down the line. So I think my message around this would be that there's lots of work been done. We'll continue to embed the actions required as a result of those 2 pieces of work. But I think what we will see is we will see increased reporting of these incidents, because all of our staff are going through the training, and that training encourages people to report it. But if they report it, it then means that we can act. So Richard and I have personally yellow carded and red carded a number of patients over the last 6 months, which will support this message that we're trying to give both inside the hospital and in the wider community.
Chair, can I just briefly follow up with just 2? That's really clear. Thank you, both of you. Just 2 brief follow-ups. One is, so clearly a lot of work is taking place. Does the wider organisation know about the extent of that work? Because I think part of this is about explaining to people all of the steps that we're taking. And the second bit is, I think we're measuring we're saying success in 21-22 will be a return to national average against these indicators, and I think we should challenge ourselves to do better than the national average.
So if I may just come in terms of does the organisation know? This was one of our, you said together we did actions based on learning from 2019 staff survey results, and also when we did an extensive learning from COVID focus group and interventions halfway through last year. So we've just completed our quarterly update where all of this information that Julie's just alluded to is in. So that will be communicated out across the organisation as part of the end of April update, and that will list everything around you said together we did. And that's why we take this approach with our action plan, really, because this is about how do we continually learn, define what we're going to do as an organisation, and then communicate it. And I think that's really important for us so that colleagues can see that we are listening and that actions are taking place, and for everyone to have a bit of a broader understanding of that. So that will be done there. In terms of aspirations, I've put in there in terms of what we would like to see, and the percentages in there is the expected increase in percentage. But again, very happy to take that away, Julie and I, to look at that in terms of, do we think we could aspire for greater? I think it's a fair challenge.
Thank you. Paul, you had a comment you wanted to come in.
Yes, thank you. Morning, everyone. I'm Paul Robinson, the Chief Financial Officer here at the Trust. Mine was a general comment on the positive aspects of the staff survey. In my role as Deputy Chief Executive, I was talking to a group of new starters at their orientation day a couple of weeks ago, and was talking about the positive aspects and also our award-winning year as well. And it was well known by everyone on that was starting, and was clearly a factor that had attracted those some or if not all of those people to the trust. So it really works in terms of, it's really working in terms of recruitment and attracting people to the trust.
Excellent, thank you. I've got a question from Tim.
Thank you, Claire. It's really just to understand a couple of things. One, there's a relationship there between the under 21s and the over 65s. Do we link this survey to our volunteers, because we do have a cohort of that age range amongst the volunteers? And the other one is how do we share some of our learnings with our MediRest colleagues, because some of them may not have been part of this survey, but they would be seen externally or by the person coming through the front doors that they are still part of Sherwood Forest Hospital. So I think there's a lot of opportunity here for shared learnings.
Thank you for that, Tim. In terms of working closely with our volunteers and our lead for volunteers as well, that role is actually part of our People, Culture and Improvement Committee, and we do share our staff survey results wider, and where we recognise such areas of focus, we have actually engaged to actually see if there's anything particularly that we can do to improve experience. And similarly, although we don't have access to the MediRest staff survey results, we equally try to interact and engage with regards to the Sherwood, other Sherwood colleagues' experience, because we are keen that we see them as part of Sherwood. And actually, you know, we want everyone to experience the same level of working in the organisation. So we do try to link in, and I know Richard's probably would like to share something further with regards to some of the particular sessions that we have had more recently with colleagues across MediRest. So I think it's fair to say that with the volunteers, I'm confident that we've got a link in there, and we work closely with our lead for volunteers, and also I suppose the ongoing work with MediRest to try and increase their experience of working across the organisation. But there's more to do there, I think, Tim, is fair to say.
Thanks, Emma. Richard, did you have a comment on MediRest you wanted to come back in?
Yes, thank you. So yeah, really good point from Tim. I don't think on reflection we've drawn public board's attention to some of the work that we're doing with the wider group of colleagues who work at Sherwood and who are not directly employed by the organisation. So myself and some of the execs have been meeting with MediRest colleagues every month now since I think it was September, possibly October, and I write directly to them on a monthly basis. The four things that we're working very closely with the MediRest on-site leadership team in response to concerns that have been raised from colleagues. The first thing is about ensuring that they are treated as an equal part of the Sherwood team. And I last met with, we had 2 meetings with them last week, And whilst it does fluctuate from a month to a month basis across the board from MediRest colleagues, there was more positivity than recently about feeling that they truly were being respected as part of the team. The second bit is around effective communication. That's not through the Sherwood routes of communication, but it's through the routes of the MediRest leadership team. And I know that they are putting in quite a bit of effort in terms of reporting on a daily and a weekly basis about some of the changes that are taking place. And again, there was some positive news about that. The third bit was, in particular in January and February, there'd been concerns about the individual safety of MediRest colleagues as they were caring for patients with COVID. And Julie Hogg has joined the conversations to provide assurance that that wearing PPE, social distancing, hand sanitisation were very practical steps that would keep those MediRest colleagues safe. And as we heard earlier, the rates of COVID in the organisation across the community have reduced dramatically, and long may that continue. And just on that point, we've also all MediRest colleagues acknowledged that they have been given equal opportunity to have the vaccine, which is positive, and I think their uptake is in line with the 9 out of 10 rate across Sherwood. And then the fourth bit was around these colleagues were doing exceptionally difficult jobs pre-COVID. Then the demand on them had increased at a time when some of their colleagues were isolating or shielding in response to COVID. And Rob Winfield from MediRest was able to update in detail about the steps that they're trying to take to increase the number of people working there. So I felt a bit disappointed and despondent a month ago. Maybe that's about the fluctuations in my emotions, but this month I felt far better that things had improved and some of the efforts we're putting in were working. So I hope that answers your question, Tim.
No, it's great, thanks. And I also think, Richard, I don't know whether it's possible, but with some of the stuff we do on the engagement and communication, I think there's an opportunity here for us to demonstrate that one team, whether that be through some of the public briefs or whatever it is, because individuals that access our services, they see us as one team. They don't understand. They don't really need to know that X employs Y and there's NHSE and NHSI and all this type of stuff.
Yeah, I absolutely agree.
Thank you very much for that. And I think that was a very helpful discussion. And I noticed as well that Claire Teeney has sort of put in a comment to just say that this is also an issue that's being looked at across the ICS in terms of key themes and responses to staff surveys. So some really positive work there. Thank you very much, Emma.
Thank you.
Okay. Moving on to the Nursing, Midwifery and Allied Health Professionals Staffing Annual Report, and that's over to you, Julie.
Thank you. So the staffing report gives you an overview of nursing, midwifery and AHP staffing capacity and compliance. As you'll know, this is a National Quality Board standard that the Board of Directors receive this report twice a year. Despite the challenges, we've had a relatively good year. We have reduced the vacancy rate by 3.5% in nursing and midwifery, which are our two professions where we have the highest vacancy rate. The People, Culture and Inclusion Committee did see a deep dive into our Band 5 vacancy rate. We've got circa 116 vacancies there, and they were assured by our plan to try and fill some of these vacancies through a local, national, international recruitment drive, as well as growing our own via apprenticeship schemes. Year, and much of this is driven by the workforce loss attributed to the pandemic. And so when you look at the plan versus actual staffing, you'll see that it's a bit of a mixed picture. I'd encourage you to look at the care hours per patient day, which shows a much more stable picture, and that shows that actually we're flexing our workforce in line with our patient demand. So we have had periods over the last year where we haven't had very many patients in the hospital, particularly during the first wave when almost everything was stopped except for COVID. We've had 274 staffing related incidents. and 8 of these are the NICE defined red flags. So the NICE defined red flags are where we've had 2 or more registered nurses per shift short, or we've seen delays in patient care. We do see a high number of incidents reported here because we ask them to report every time they use an agency member of staff as well. So I'd encourage you to look at the red flag numbers as opposed to the wider incident numbers, because we know we've seen a significant increase in agency. Despite the challenges, we've continued to implement the Safer Nursing Care tool, and that is the NICE validated tool that we use to set establishments, and the teams have made good progress with implementing that. And you can see the output from our establishment reviews this year are saying that we need an uplift of 33.6 whole-time equivalents for nursing. Much of this is attributable to the ED expansion and was already within the plan. And there are some small uplifts in medicine to support the reduction of falls, and a small uplift in gynecology to support extension of the gynecology assessment unit and a couple of additional beds. From a midwifery perspective, we have completed a full birth rate plus exercise, and that has shown we are 12.37 whole-time equivalents short there. We have secured some funding from the LM&S to support some of this shortfall, and we're seeking the additional in this paper, which has been supported by the executive team already. From an AHP perspective, they continue to maintain a strong vacancy position. They've introduced some new apprenticeships, which is really great because we didn't have any apprenticeships within our AHP communities. And our Associate Chief AHPs continue their work across the ICS, so they've been really successful and influential within that arena. Have managed to secure some funding to do some work around increasing the proportion of BAME AHPs that we have within the region, and also increasing entry into those professions from that population. So overall, my view is that we have good compliance with the workforce safeguards across nursing, midwifery and AHPs. And the view of Dave and I is that there is safe, effective and sustainable staffing. There are 5 recommendations, so I'm seeking your support for the proposed establishments that have been through our robust process. I'm asking you to note the maternity staffing position, and although there are some fragilities there, that is consistent with the national picture, and we've got a robust plan in place to recruit to vacancies and the additional posts. And to note that this paper also forms part of our evidence for the NHS resolution programme for maternity, and to note our ongoing plans to ensure that staffing remains safe, effective and sustainable. Happy to take any questions.
Thank you, Julie, and we'll come back to those recommendations. Perhaps I can just highlight something in the report. It mentions that our AHPs have been nominated as the leads for the ICS in relation to long COVID, but it also suggests that the pressures on resources may make that quite a challenge. So how do we make sure that we can support our AHPs in this process and ensure that they do have everything that they need across the system?
So the team are working really closely with David Ainsworth, and I know Dave has been much more involved in this than I have. I think it's probably a problem that is a bit wider than the ICS, because nationally I'm not sure the funding source has been agreed, but Dave has probably got more of a view on this.
Chair, if I'm just coming, I think the real risk to the long COVID programme is around the resources that are given to the downstream rehabilitation of patients. What we have been given as an ICS is a really relatively modest amount of money, which we've used to help identify and signpost patients who have the appropriate symptoms or signs into the existing rehabilitation facilities. And I think we all recognise those are already stretched in the community prior to COVID, and now we're just adding an extra layer there. So I suspect that more will come of this, and this will be a developing situation. I'm really mindful that in terms of the the initial tranche of money released to set up these long COVID clinics and the screening processes. Subsequent to that, there was really a very substantial release of research monies and 5 very large grants to try and identify exactly what will help patients and what is required. And I think once that rolls, we'll see more targeted funding, I would hope, but happy to take questions.
Okay, thank you. Paul, you wanted to come in with a comment.
Yeah, thank you. Just want to comment on the funding routes for supporting the additional workforce in the report. So as Julie said, it's gone through a robust process, including exec sign-off, and the sources of funding are either within existing resources or the majority of the increase in same-day emergency care and on EAU, or as a result of additional capital funding and work and programmes that were undertaken during the last 12 months and have all been incorporated in our H1 plan. So all fully funded and approved by executives.
Thank you. Graham, you had a question.
Yeah, thanks, Claire, and thanks, Julie, as well. I think I just really want clarity on the financial side a little bit. On page 61, the recommendation mentions funding of 1.6 million, and then on page 81 of diligent, it recommends 3.1 million. Are those inclusive? Is the 3.1 including the 1.6 or additional 2? And it would have been helpful, just there are lots of tables with costs in, but there's no real summary showing how those 2 figures have been arrived at.
Yeah, apologies. So the total investment that we're asking is the 1.6. The 3.2 includes, provisionally, we did put the critical care expansion in for COVID, but we subsequently took it out. So apologies that that's made it into the table at the back, because I thought that had come out. So the investment we're asking for today is just under 1.1 for the nursing and over 500 for midwifery.
That makes a lot more sense, because I certainly didn't recognise the second one.
Yeah, apologies.
Thank you. Barbara, you had a question.
Thanks very much. It was more about so the extra establishments post Julie, are they across the pay bands or are they largely more junior? Just sort of trying to get a sense of whether this is going to give opportunities for career progression or other.
So across ED, there is some opportunity for career progression. So there are some more senior bands and there are in maternity as well. But I think the lion's share are across our band 3 and band 5 workforce.
So some of the challenges that we've got at the moment around vacancies will chime with those bands.
I think so, except that ED don't seem to have a problem with recruiting. So Richard Clarkson, who's the head of nursing for the emergency care division, is very confident that he's going to fill these. What I'm not clear is where he's going to fill them from, externally or internally. So that is yet to be seen, but I think it could well.
Do you think there'll be any opportunities to recruit from the staff group that have come forward to help with the vaccination programme and who hopefully will have had a positive experience of being part of the Sherwood Forest team?
Absolutely, and we've already got some staff that came over to us on secondment from Notts Healthcare wanting to stay with us as well. So I think we will see more of that. I think the other thing is that we're not really seeing the end of the vaccine programme, so we may have to wait a little while for that to come to fruition, but I would hope so.
Thank you.
Thank you very much. Andy, you wanted to come in with a comment? You're on mute, Andy.
Sorry, newbie.
Newbie.
Thanks for the report, Julie. It's really helpful. It's good to see the progress that you've made with some of the staffing gaps. I suppose it's probably a comment for you and Dave, really. So there's an opportunity here, I think, with long COVID at system level. And it doesn't all have to be face-to-face with some of the more specialist stuff. There's an opportunity with virtual. So I just wondered if we've had any discussions around that with partners or at system level, particularly in relationship to the National Rehab Centre and the relevance of that. And the second thing is clearly pulmonary rehab is going to be important for a tranche of long COVID patients, and it's been a long-standing issue for us in terms of staffing. So great that we've got a strong position with AHPs, but I just wondered where we stand with pulmonary rehab.
Dave, do you want to take that one?
Thanks. Yes, just picking up the technology. So absolutely, and that's a key component of that. And we have tried to feed this into the facility down at Stamford Hall. The whole system description of what that looks like is still awaited, and I think that will be forthcoming with time. In terms of the pulmonary rehab, again, we're just really starting to get initial information on what this is going to look like for us. A significant component of this is expected to be out in the community, but we are starting to see referrals into our respiratory clinics with people who have ongoing symptoms post a wave 1 COVID, and I think that will be something that we will need to develop and keep track of.
Helpful. Thank you, guys.
Great, thank you very much. So returning to the recommendations, are we agreed? I don't see any contraindications to that. We agree to all of those recommendations, so thank you very much, Julie.
Thank you.
Richard, we're now moving on to strategic priority 5. You're going to take us through the ICP strategic objectives update.
Thanks, Chair. Yeah, I will. I'll start with an apology. I was reading through this yesterday, and I am aware that the title on the agenda is the ICP strategic objectives update, and when you read the paper, it doesn't update on the strategic update. So apologies for that. The reason being, and I accept I didn't make it clear, is we don't get an update on our ICP objectives until the 20th of May. The paper is not written until the 13th of May, so I can't, the paper simply isn't written, and even if it was, it wouldn't be possible to bring it here before it goes through our public ICP board. I will ensure, depending on how this conversation goes, either to bring it back here in June in full, or we can share subsequently in another way. What it does, though, hopefully, the report we're seeing today is the same report as the one that is going to our public Nottinghamshire Integrated Care System board meeting that Claire, Ward and I are joining later today. As a reminder, we're one of 3 ICPs. Each ICP is updating on a monthly basis to the Integrated Care System, and it updates on the 3 key areas of focus as described here. What I would say and conclude with is the point that I made earlier. Obviously, the running of an acute organisation across 3 sites during COVID and post-COVID does take up a lot of the executive time, the wider senior leadership time. We recognise that the integrated care system by default is gaining traction, and certainly for Simon, Julie, Dave, Paul, actually all of the execs, I'm looking around at all of the execs, is taking up a huge amount of our time, and we only have a finite amount of time to dedicate to work. So the ICP is being squeezed at the moment, and I would go back to the conversation that I mentioned in my board update at the beginning, that we will be having in the next month or so. I think a really interesting and possibly exciting conversation about the strategy for Sherwood going forwards. And I think that is more about continuing to try and tie ourselves to the integrated care partnership across mid-knots and evidencing that delivery at system level. So I'm sorry it does not answer the agenda title. I'm aware of that. We can come back in the next month, but it's simply because it's not going to the ICP board for another 2 weeks.
Okay, thank you. Barbara, you have a question on it.
Thanks very much, Richard. So just recognising what you've said, I'm interested in the section of the report that looks forward to the year ahead. So it talks about the 7 priorities for 21-22. I suppose what I'm looking for is some more clarity about what good would look like for success against those priorities by the end of the year ahead. I wondered, and given what you've just said about time pressures and so on, which I can completely understand, whether having 7 strategic or priority areas is in fact realistic.
Very good question. Sorry, I think I was on full mute then. Yeah, good question, Barbara. So Lorraine Palmer, who's heading up the Midnights Integrated Care Partnership on a day-to-day basis, she and I were catching up yesterday for our fortnightly conversation, and we had a similar conversation about the prioritisation. What I think this report doesn't make particularly clear is the relationship between, as you identified, these 5 strategic, or these 5 areas of focus and the pairs of aims that underpin the integrated care partnership strategy. The conversation that Lorraine and I was having yesterday, and we will be bringing back to our public board in 2 weeks' time, is about how these focusing on those 7 areas support the delivery of our longer term commitment. I also think, hopefully this is answering your question, I also think whether we're talking about the integrated care system or the integrated care partnership, whilst the 7 areas of focus listed in the report, for example, the second one being the continued development of primary care networks and community assets to support place-based models, that is a valuable thing to be focusing on. But we also need to remember that we have services to restore, we have financial pressures, we have the welfare and well-being of colleagues, etc., etc. And I think they are the areas that the organisation, whether it's our statutory organisation, possibly the integrated care partnership, but certainly the integrated care system, are going to be successful, be monitored on. And we have to find a way of delivering both of those, the stuff that is understandably politically important and the things here that we view as of local importance as well. Does that, I think I've more of acknowledged your question rather than answered it.
I think that's a fair assessment, yes. I suppose, but just being clear about what good looks like and how it all fits together would be what I'm after. But I take your comments. Yeah.
So just that particular bit about good. What my final bit would say, and I'd be keen for us to continue in this vein, but certainly want to debate it. I think we are still we're still finding, well, I think all systems are still finding their feet across the country. And I don't think some of the things that we are focusing on we will be able to measure in specific ways, but I think quite a bit of it is about building momentum and trust and traction that hopefully, as a lot of the CCG infrastructure moves into the integrated care system, enables us to gain greater autonomy to deliver at place level. So some of it will be good is delivering X by Y, but I think I would urge that some of it doesn't translate into those specific objectives for us to deliver on. Combination of the two. But we will come back in a. So if Chair, obviously entirely up to you. My preference would be to maintain a bit of focus on me and others. That in a month's time we come back with the 2021 update, which is what we had said we would do today. But we also provide the framework for delivery for 21-22.
Okay, that's very helpful. Thank you very much, Richard. Don't have any more questions, I think, on the ICP paper. Perhaps you can then take us on to the ICS compact, which is going to be discussed and hopefully approved at the ICS later today.
Yes, so this compact is going to all of the statutory organisations across Nottinghamshire that are members of the integrated care system over last week, this week or next week, depending on when our public boards are. They're being brought here for, it's been brought here for approval. As the cover sheet said, we were given an opportunity to respond and we did respond within the timescales, recognising that our response didn't involve the opportunity of everyone around the board table to respond because of time pressures, but also I felt it would be horrendously complicated to pull everyone's responses together. What we're trying to achieve, or what the integrated care system is trying to achieve through the compact, is a recognition that it's our collective and individual behaviours that will drive delivery over the coming years. My view, as I've touched on before, about system working, is that system working can be incredibly complicated. It's also a huge opportunity for improving the services to the communities that we serve. I think three of the things that underpin successful system working or behaviours is a recognition that we need to take steps to include the views and the voices of all. The second one is we know that change, and ultimately the system is about delivering change. Change is easier to deliver and more likely to work if people feel they are in charge of the change, not so much necessarily the execs sat around the table, but the clinicians actually delivering the services. And then the third point is we know that trust dictates the pace of change. And I think to an extent those 3 points are pulled out in the paper. A lot of it is reconfirming information we already know. The bits that are of most interest to me are on the third page of it. These principles will be underpinned by the following core values. Number 1, open and honest. Number 2 is being respectful. And number 3 is being accountable. And they are the areas we need to focus on. And the conversation we had, I referenced earlier today, we had yesterday with Notts Healthcare and Nottingham University Hospitals, was very much about the compact makes sense, but it's actually what do we all do when we exit the room. So it's been brought here for approval, and it's the chair said it's going to the integrated care system public board later today.
Thanks, Richard. Paul, you've got a question.
Yeah, thanks, Richard. It was on that final point that you just made, actually. So I agree. Page 3 and those principles are the key components. So I was thinking of the word, how are they going to be enforced? It's probably a little too strong language, that, but how do we make sure, going back to your point, that round the board table at the ICS, maybe one way of ensuring that all partners adhere to those principles, but how do we ensure all partners adhere to them outside of the board table?
So I think there's 2 aspects to that, and I'll form a parallel. I'll answer your question, Paul, by giving the answer that I share with people when they comment to me about, oh, I've seen a colleague in the organisation not wearing a face mask or not parking appropriately. And the first thing I say is I wholeheartedly believe the only people we can control and influence is us as an individual. So I know you weren't saying this, but I sometimes think, oh, I wish X behaved in a different way. Well, I need to reflect on my behaviours as well and ensure that I'm behaving absolutely consistently in line with those 3 principles that you identified. And I think there's a bit about, by doing that, it does possibly sort of raise the bars for others and the collective effort. The second bit is, and it's they're probably both as difficult as each other, the second final bit is whether it's round possibly a trust board table or an integrated care system board table, any sort of environment, we all tend to sort of agree with each other and share pleasantries, and we don't have the difficult conversations. And I think we need to move towards a culture where we can behave in line with our values, but we feel that it is appropriate to disagree as long as it's done with appropriately. So the second point for me is about sort of calling out the behaviours, and I think it's possible to call out behaviours when I can call out behaviours when I'm absolutely clear that personally I'm behaving in line with those values. And cards on the table, I'm imperfect like the rest of us, and I don't always do it. So I'm going to focus on the first bit, and I think by doing that it enables the second bit. Does that sort of answer it?
Yeah, almost entirely, but it prompted me a further question, if I may, and that's about the onward communication of this compact. So because it relies upon not just those members of this board or the ICS board understanding that those are our principles and our behaviours and our ambition of ways of working. So how do we do that?
Yeah, so we touched on that. You and I can get on with our counterparts at Notts Healthcare or NUH or the CCG, but it's far wider than that, and that will be an ongoing piece of work. And going back to the bit about trust dictates the pace of change, clearly the evolution of trust can also take a long time. It can evaporate overnight, but for it to be built, it can take weeks, months or years. I actually, as I said earlier today, I think the relationship between our organisations is probably tighter than we think. So that's a decent foundation stone, but we do need to be communicating this effectively. I agree with that.
Thank you.
Thank you. Dave, you wanted to come in?
Oh, thank you. I think mine's turned into a comment rather than a question, because I think it's very similar to what Paul was asking. So I'm just mindful that the ICS has been in existence for at least 5 years. It's probably 7 years or so. And I just wondered when we think that we'll be able to no longer spend time describing these principles about how we all need to behave, the core principles, and spending so much time focusing on that. It's clearly a massive problem for us, but it's, I think we would all recognise it's a huge barrier to actually us making any change, and we do need to actually put it to one side and say, let's do something.
Yeah, I agree with the comment. As we said, we mentioned, I think you and I had a conversation yesterday, Dave, and Claire was there. We all focus around governance when we don't want to have the difficult conversations. So possibly by 2031, we would have moved away from conversations about governance.
Well, perhaps I can bring Andy in for a comment at this point as well.
I noticed you saved me to the end, Claire. Thank you.
I did.
I mean, I guess on the latter point, Dave, you have to just get on and do, don't you? Because the principles are the things that help you build trust. So I'm sure they're right. They're not new. Living those is the key. And actually, by doing the stuff you can do rather than focusing on the stuff you can't, you help to reinforce that trust. So I think for the bits of the system that can progress and make progress forward, they should do. And that will help build the trust. I suppose my second observation was these principles have to get below the exec team. So it's important, I think, with the leadership development at system level that this becomes part of what we say to the leaders who are below exec level, because really them following the principles is more important than the execs, I suspect. And I suppose the third thing in section 6 in the agreement, so it might be something to clarify this afternoon, is what do we mean by external scrutiny? So how are we going to hold ourselves to account? So Richard's right, there's a personal accountability. You can review all decisions, you can review board, but actually what are we prepared to do? Is it part of the development maturity matrix for the ICPs and the ICS? Are we going to ask NHSEI to give us a comment? I think it'd be really helpful to get the ICS to be clear what it means by external scrutiny.
I think that's really helpful. Richard, did you want to come back in on that, and then I'll bring in Simon? Okay, Simon.
Sorry, yeah, I will pick on Andy's point up this afternoon.
Okay.
Thanks, Chair. I think sometimes we can get a bit sort of despondent about ICS and feel like, oh, what is it doing? But certainly, I feel COVID has galvanised a lot of some of the partnerships across the system, and certainly in some of the cells that exist now, they're doing really good partnership working with like 6 or 7 organisations involved in like the discharge cell and areas like that, and we are making progress. And so there's sometimes it's like, let's not overthink it. Let's just get together with some people and make some stuff happen. And I think some of that is going on.
Okay. Well, I mean, I think anybody looking in at all of this discussion from outside will be wondering why we have these challenges and these behaviours which are perhaps preventing us moving forward, and that those have existed over a long period of time. And I don't think a very important point that's just been made about making sure that everybody in all of these organisations and across the ICS recognise the value that comes not just for patients but also for their own working environments in being able to get on and deliver and be productive right across that system. So hopefully we will get out of the ICS more commitment because people will actually see the value that they will get from it and the benefits for them, for their organisations, and most importantly for patients across the system. So can I take and assume that we are approving this compact, this partnership agreement for the ICS this afternoon? I don't see any indications otherwise. No, okay. Thank you for that, and thank you, Richard, for taking us through it. Now on to our patient story, and we've been joined by Lauren Brown, who's the ward leader, and I think Leanne Beardsley and Debbie King. Is that right? Have we got all three of them here for the patient story? Hello, Lauren. Hello, Leanne and Debbie.
Hello.
Hi.
Hi.
Excellent. Thank you very much. Can I hand over to you to take us through the patient story? And welcome to the board. You're on mute, Lauren. I didn't know whether, Julie, did you want to introduce some of this?
I don't think this really needs very much introduction. So Lauren, Debbie and Leanne have been supporting patient care through the COVID restrictions, and what they've done is something really innovative. We're really keen to roll it out and to share it with you today. So I'll hand over to Lauren.
Good morning. Can you hear me now?
Can, thank you, Lauren.
I do that at every meeting. So good morning, I'm Lauren. I'm the sister on Ward 12 here at Kingsmill. Over the past few months, with the support of Debbie and Leanne, we've rolled out the Carers Passport and Rita on the ward. So Rita is a reminiscence interactive therapeutic activities. We have managed to create a video to explain all of this to you, and we're extremely proud as a ward to show how much of a difference this has made for all of our patients, their loved ones and the staff itself. So I think if there's any comments or questions afterwards, we'll be more than happy to answer them.
Thank you.
Hello, I'm Lauren Brown, the sister of Ward 12 at Kingsmill Hospital, Trauma and Orthopaedics. Today I'm here to talk about the Carers Passport and Rita and how we've rolled them out on our ward to be able to help our patients. Most of our patients are admitted due to a fall, either at home or in the community or in the hospital itself, usually resulting in a substantial fracture that requires theatre. Many of our patients have pre-existing medical conditions that could have caused them to fall, or just exacerbated by the fall, meaning that the acuity of our ward is quite high most of the time. A lot of our patients are elderly patients, and so we have some with dementia, some with Alzheimer's, and then there is a significant amount of our patients that then suffer with delirium pre and post-operatively. I want to introduce a patient and their loved one and how we've been able to help them during their stay. So we first met Anne in October of last year. Her husband has cared for her with Lewy body dementia for 5 years previous to this. He has had an extension built for a downstairs existence and a wet room to be able to care for Anne at home, and sadly during the build of this he wasn't able to keep her safe, so he popped her into respite for a few weeks. Very soon into her respite, Anne fell and she broke her hip.
Hello, my name's Ray, come from Ollerton. I'm looking after Anne. We've been married 52 years. We've lived at Ollerton now for 34 years. Anne used to work at the care home in Ollerton at Bishop's Court, a lot of the time looking after people with dementia. She really liked her job, and unfortunately now she has dementia. and it's hard to take, but she's doing well, and I'll look after her the best I can. But every so often I've got to put her into a home, and that's when she had her accident and she broke her hip and she came into hospital. But now she's getting over it, and I want to get her home to try and wrap her in cotton wool and keep her safe.
During Anne's first admission, she came in, she was admitted with a fractured neck of femur. It was during COVID and lockdown, and so unfortunately Anne's husband wasn't able to be by her side all the time. She was, right from the off, we knew Anne was going to need enhanced observations. She was very confused, very agitated. Even though she'd got a broken hip, she didn't want to stay in bed, which was causing her extreme discomfort. For Anne's safety and her well-being, we used chemical restraint on the ward. We gave her lorazepam to try and keep her calm, try and keep her settled and prevent herself from hurting her any further. Ray, her husband, was allowed to visit 1 hour for 3 times a week, and during that time Anne was much settled, and after he'd been, she was much more settled than she had been, but that would soon unravel once she'd forgotten that he'd been.
It felt as if I'd deserted her.
We managed to discharge Anne back to the respite, and sadly within 2 days she returned with a periprosthetic fracture, having had another fall. Anne was with us for a further 14 days following this, and again, very same principle. Husband was only allowed to come for 1 hour 3 times a week. We had to use chemical restraint. She had a carer sat with her all the time, and was wandering the ward morning, noon and night, trying to get into other patients' bedrooms, trying to get into the offices, trying to get into the drugs room. So this time when Anne was admitted following a 3rd fall in the nursing home and a 3rd fractured hip, we decided that Anne would be a prime candidate for the carer's passport. We rolled it out and we rang Ray to say that he could come in and sit with Anne, and he was very up for it as soon as we said this. The carer's passport allows the loved one or a carer of a patient to come in and to provide as much or as little care as they want to. So they can be involved with meal times, with eating, drinking. They can be involved with personal care. They can have a meal with their loved one as they would at home to encourage our patients to eat and drink. We provide them with little things to help them too, such as free parking, being able to use showering facilities, toilet facilities, even just a cup of tea. And because we were able to roll this out for Anne and for Ray, it made a difference then right from the off. As soon as Ray walked onto the ward, he broke down in tears as soon as he saw Anne, because sadly he hadn't seen her for more than 2 months due to lockdown again in the nursing home. By rolling out the carer's passport and the use of Rita on the ward, it's allowed us to, as a team, communicate and work together better than before, able to change our way of working and to provide better care for our patients. It's allowed us to communicate and work together with their patients' loved ones and the wider community as well, which has been very difficult throughout COVID. Sadly, it's meant we've not been able to have visitors. We've not been able to get to know our patients and their families and how their injury has impacted on their lives as much as what we would normally. So this has really given us the chance to be able to open our doors again, accept people back onto the ward and show how our visitors and their loved ones and our patients' loved ones help us each and every day to get to know our patients and be able to care for them better.
It's been brilliant in here. I've been able to come in every day and sit with her, help her with her dinner and tea. I get here about 9:30 and I'm here till about 5 o'clock.
For him literally just to hold her hand while we do personal care is just a massive difference. It's just made such a difference because he can literally be there to support her but also support us.
And I can spend time with her. I can be with her all the time and walk with her. She loves walking, as all the people at Ollerton know.
So having these relatives come in to sit with the patients, we can just get a better insight into them and able to help them getting their loved one back on the road to recovery the best way possible that we can. they allowed Ray to go down to theatre with her. He went down all the way through to the holding bay. I went with them as well, just to give them extra support. And he went all the way through to the anaesthetic with her, where she had a spinal rather than a general anaesthetic. And this helped her recover better. She wasn't as out of it as she would have been if she had had a general anaesthetic. And then Ray was allowed to come back up to the ward and wait for her to return. And this helped keep Anne really calm. And we've seen a massive difference from her previous operation that she had with us.
Obviously, we can personalise a patient within Rita. Also, Ray being there gave us a massive insight as to what Anne liked when she was a lot younger, what her favourite movies were, what her favourite songs were. And then we can literally just tap it into Rita and we can actually find either the movie or the songs or a bit of Bee Gees or a bit of ABBA or just something along the lines from that generation. And it just automatically calmed her. And it was also then able for Ray to then just sit and hold her hand and just literally just be with her.
They can also give us an insight to what they are like at home, so we can get to know them more as a patient and their personality.
Every day I fetch an apple because she will not clean her teeth. But if you give her an apple, she eats it and that keeps her teeth clean.
As a ward, it's allowed us to aspire and improve the care. It's allowed us to be better than we were before, to work in a different way, and to look at everything as a whole. Not only has it improved it for our patients, it's improved it for our staff. Caring for a patient on enhanced observations can be so tiring. It can be so mentally draining. All we want to do is provide our best and keep them safe, and at the end of the day sometimes you go home and it's been a really, really tough day, and to be able to have a patient there that is so much calmer and so much more relaxed than they ever have been is exactly what we want. This is what we, for every patient, we want to be able to keep them safe and provide them with that level of care that they should always be getting. And during COVID, it hasn't been the same. We've had to sit with those patients. They haven't been able to tell us what they want. They haven't been able to tell us what they need. And over the phone, it's not the same. That 1 hour a day for 3 days a week, it's not been the same. Having somebody there 7 days a week to be able to help provide care for our patients, it's made such a difference, and it's going to continue making a difference. It just works.
For me, it's the best thing since sliced bread.
Thank you. That was fantastic. Lauren, did you want to come back in, or Leanne or Debbie, before I open up to questions? Okay, so
no, I'm happy.
That was a fantastic case study, really patient-centered and focused care, and thank you to all of you, but also to Ray for taking part in that and being able to explain what it meant to have that opportunity, not just for himself, but also for Anne. I think I've got a question from Tim. Do you have a question or a comment?
It was a comment, but I'll highlight it. I think it's a fantastic initiative, and there's so many learnings here. And they said it, and Julie highlighted it's looking to roll out in other areas, especially around learning disability community, because we've had similar examples before, but also anybody that's vulnerable, and it could be from any way, shape or form. And certainly with our disability community, I think there's a massive opportunity here.
Absolutely. Andy, you wanted to come in with a question.
Yeah, it's fantastic. Absolutely brilliant. Well done. The guy said it at the end, didn't he? It just works. I just wonder what the potential is for this to be a bit more upstream. You know, we'll have thousands of people like Anne across our community, and having this information accessible to all people that are trying to care for them will be important. I just wondered how visible what you're doing could be across a wider community.
So from a ward's point of view, we are discussing this with each patient that comes in that we feel would be beneficial of the carer's passport. Not every patient has a relative that's able to come in, sadly, but that's how we're trying to roll it out at the moment. I think Debbie's probably got some plans for trust-wide rollout, and I'm more than happy to support in any of those.
Julie or Debbie?
Debbie, yeah.
Yeah, so we will be we've trialled this on a few other wards and had very similar outcomes to what Lauren's you know, sort of gone through with us. So we know that this works. We will be rolling this out. We're hoping to launch this in Carers Week, and our comms team are going to support us with a social media campaign. Hopefully this over time as well, it fits in with the NHS long-term plan, so there is a commitment to encourage that national adoption of the carer's passport, and there is a KPI for primary care to actually start to identify that, so hopefully we will be able to make that connection. The next stage of it is obviously to look at how we can maybe work with this from an outpatient perspective, and then start to be able to identify people that are, you know, sort of pre-admission coming in. So again, supporting our vulnerable dementia, learning disability or complex need patients, so that we're more prepared as well. So we're definitely sort of on the start of our journey, but we've got much, you know, sort of bigger plans to make that connectivity across different areas.
Excellent, thank you. Simon, you wanted to come in with a comment?
I think Richard might have been before me, Chair. Well, anyway, I'll make one. Just a couple of things, really. Obviously, it's absolutely fantastic. One of the hardest things, which must have been really hard for colleagues working on the wards, but also for patients and their relatives, was the sort of like their inability to see each other during all of COVID. I can't believe how difficult that must have been for both relatives and patients, and also for the wards having to pick up extra work that it generates. And then, so well done. I mean, it's absolutely superb. And then the other thing that I did want to say was, as you'd imagine, sort of Lauren runs the trauma and orthopaedics wards, and since lockdown as restrictions have eased, we've seen a fair amount of trauma patients coming in. So just wanted to say thank you to Lauren and their team, and all the doctors and therapists up there for all their hard work at the moment, because it is incredibly busy. So thank you.
Thank you. I'll feed that back to everyone.
Wonderful, thank you. Richard, apologies, I left you out.
No, not at all, and I will say exactly what Simon did, so apologies for that. Thank you, Lauren, Leanne, Debbie, for that really powerful and impressive. Thank you for the huge difference that you're making to patients and their families on a day-to-day basis.
Thank you.
We've got a question, I think, from a comment or question from Graham.
Thanks, Claire, and thank you, Lauren, everybody. I thought absolutely brilliant, and yes, something we really do need to roll out. Recognise, of course, you don't always have the patient's relatives are able to do it, but where they're able to, it was a crossover for me for something as well that we talked about earlier on, about one of the issues from our staff survey around violence, and I can see this as helping make a big difference in that area, because if they've got relatives with them, then hopefully we'll see a lot more, less wandering around, and a lot calmer as a consequence. So I think as an initiative, it's got so many benefits. Really well done, thank you.
Wonderful, thank you very much. It's a brilliant idea and obviously been delivered in such a good way. So thank you to all of your team, from the whole of the board and the trust. Thank you. Okay. I think now we're going to take a break, and then we'll be back for 11 o'clock. to look at the SOF. So thank you to all of you, and we'll see you again shortly. Find a cup of coffee. Welcome back to Sherwood Forest Board. Thank you for joining us after our short break. I'd now like to move on to our single operation oversight framework performance, and perhaps Richard, you'd like to introduce this and other members of the board.
Thank you, Chair. So this is the single oversight framework for Q4, the end of the year wrap up. We trailed some of the items earlier today, in particular the focus around quality, safety, patient experience. I'm going to invite Claire Teeney, Director of People, and Emma Challenge, Director of Culture and Improvement. First of all, we will then move on to quality, safety, patient experience with Julie Hogg, our Chief Nurse, and Dave Selwyn, our Medical Director, then on to access and timeliness of care, wider performance with Simon Barton, the Chief Operating Officer, and on to finance with Paul Robinson, who is our Chief Financial Officer and Deputy Chief Exec. So Claire and Emma, first of all, please.
Thank you very much, Chair, and thank you, Richard. So I'll start really just covering 2 to 3 key areas from the single oversight framework, particularly relating to culture and what we're also doing in terms of further progressing our culture for improvement in Sherwood. So I shared earlier our staff survey results, and some of that links back to Sherwood continuing to be a great place to work and receive care. And very much of the focus over the last couple of months, particularly and within the last month, is supporting some teams in areas with some decompression sessions. And what that means really is we've been working particularly in critical care and in theatres around continuing to listen and learn of experiences over the last 12 months, particularly in terms of what worked well, what didn't go so well, and what we want to continue to do going forward. And some of that decompression work also involves around the personal impact of COVID and supporting colleagues' future wellbeing and welfare needs going forward. So there's been some really focused work working with teams in areas over the last month particularly, and that continues. And we will continue to provide those bespoke offers as and required. But equally, what we've also been doing is building that into a resource pack, similar to what we did earlier in the year around reconnecting colleagues back into the organisation and reconnecting teams. And that's called Building Better Together. And that's where we've got tools for line managers and support available to help in terms of continuing to learn, but support people moving forward. So that's what we've been doing, particularly focused there. The other 2 things is continuing our journey as an organisation around a culture for improvement. So we've taken the opportunity to do a total refresh of our continuous improvement training in the organisation, and that's around looking at our quality improvement training and how we deliver that and how we support colleagues in those tools. Understanding in order to lead their own improvement initiatives going forward. So we've done a total refresh of our training offer, and that's going to be available from the middle of this month onwards and relaunched fully from June. And that's also involves us about how we support at a system level as well around improvement. And then finally, I just wanted to mention that something that we learnt in our last learning from COVID and staff survey results was around our colleagues wanted a more easy way and access to sharing their ideas, the suggestions for improvement. And in April, we launched an initiative named by our colleagues called Bright Sparks. And really what that means is that colleagues are able to submit ideas, suggestions for improvement, and that we acknowledge those, get back in touch with the colleague and look about how we can support and nurture that idea or opportunity. Again, really trying to encourage that culture for improvement and empowering our colleagues to lead on those initiatives. And I think within the first 4 to 6 weeks of that, we've had over 50 ideas and Bright Spark ideas and suggestions come in. So we continue to support colleagues, but we're also in very much of a frame of continuing to grow and improve as an organisation. So those are just some of the key things that I wanted to highlight. Happy to take any questions or hand over to Claire.
on mute there. Thanks, Emma. Do you want to hand straight over to Claire and then we'll take questions?
Thanks, Emma. So I'll start off just with regard to health and wellbeing. Over the quarter, sickness absence has reduced, and we're now at a position which is at 3.5%, which is good to see, and that helps improve our overall capacity. Notwithstanding that, the activity in occupational health still remains high. It has dropped over the quarter, but it's still higher than we would normally expect. That, though, should be seen as a good thing, because I think the fact that people are accessing support will correlate with the fact that we are enabling people to remain at work or return to work sooner than they perhaps otherwise would do. During the last quarter, we did introduce psychological support into the occupational health service to work directly into the clinical areas. That has been well received, and we are seeing a marked uptake in the people that are accessing that support at both the group level for group interventions and also on an individual level. In terms of occupational health and the psychological support, we are this month doing an evaluation to assure ourselves around the uptake and to ensure that the people that might be the ones that need support are the ones that are indeed accessing both of those services, and we'll report back on that through to the People, Culture and Improvement Committee once that evaluation has been done. Vacancies overall are low. That's as a combination of both turnover reducing and recruitment remaining strong. We are, though, cited on the areas where we still have got some pressures around vacancies, and some of that was referenced earlier by Julie in her staffing reports, and particularly around maternity. Although, as Julie did reference, we have got plans in place to support where we have got vacancy gaps. Overall performance around appraisals and mandatory training, underperformance on what we would normally see, but actually that drop is not unexpected because it is work that we did step down during the pandemic period, and we are on getting that back on track now. So we don't see any problems with a return to where we would expect on both of those fronts. That's all from me. Thanks, Claire.
Thank you very much. We don't appear to have any questions at the moment. I'll just say as you say, it's a very good result for the mandatory training and the appraisals, given the set of circumstances that the workforce have been under for the last year. So it doesn't look like you've got a very big gap to close there, which is excellent news. So, okay, I think we may have a move on now to Julie and Dave. Thank you.
Thank you, Chair. So I'll start if that's all right, and Julie will bring her in. So board will recognise that the soft displays a deterioration in the quality standards, and with the Chair's permission, Julie and I would like to go into some of these metrics in slightly more detail. I think we're all mindful that this soft represents the quarter or the period of time where we had unprecedented and extraordinary pressure across the whole organisation, and we've been coming out of wave 2 into wave 3 during this period, and so we might reflect that it would be particularly unusual if everything had remained as normal. Just to give some additional flavour, really it's very easy to forget how relatively recently we've had developments in our ability to track COVID infection, and during this period of time we developed and managed to embed robust mechanisms of testing our patients at the front door when they first hit our organisation, and prior to this we were treating them on pretty non-specific symptoms and trying to decide whether or not we needed to isolate or not isolate them. And at the same time, we were probably weekly and often daily, moving significant numbers of patients around the organisation across the acute wards to ensure that our oxygen supply to these very sick patients was safe. So I and just before I get into the metrics, the other thing I would just say to board is that, and to some degree of reassurance, the metrics coming out of the following months into the next quarter look much better. So in terms of the metrics I'm going to pick up, so I'll pick up the never events. So initially this was 4, it's now downgraded to 3 after the work that we've done in the investigative period. These I think have been mentioned at Trust Board before. There's the wrong tooth removal and the aspiration of the right knee in the wrong patient, and the removal of the wrong skin lesion in a dermatology setting. In terms of the investigation, most of these, or many of these, are still ongoing, but the learning we've done around that, the wrong tooth removal, just to remind board, this as a never event has now been removed from the list, and had we declared these never events at a later date, we wouldn't be reporting necessarily on them. But having said that, there is obviously learning to take from these incidents. So we've had increased support from NUH. We provide a joint service with NUH with our dental team. The aspiration of the knee, we've identified that there has been a lack of consistency in how we consent these patients. It's obviously around the positive patient identification, but there's been a lack of consistency across the services that do joint aspirations, and so we're embedding improved lock SIPs processes to strengthen that. And then the removal of the wrong skin lesion, again, we've used that to drive forward some of the technological advances across the organisation, and we've got the digital photography platform on Nerve Centre now move forward to enable the team to capture these lesions to help with the identification. Very disappointingly, Dr. Haynes did remind me that we've had a similar never event to this in the past few years, and despite the strengthening that had gone in at that stage, it has reoccurred. In terms of moving on to the incidents, so we've reported through Quality Committee, given an annual report on the number of serious incidents that we're reporting, and the national data capture of this shows, the National Reporting and Learning System shows that we're not out with where they would expect us to be as an organisation. And what I would say about the serious incidents and the investigations occurring, I think we've strengthened the process, and we now have better consistency, so that when these incidents come for sign-off, they come to Julie and I. The quality of the report and the consistency of the report and the actions are of an improved standard. I'd also note under that point that we've been approached by HSIB to act as a pilot site to allow them to develop and review and strengthen their national investigation of occurrences, and that's really to our credit. I think that they've recognised that we have strong processes in place. So I might just stop there and hand over to Julie.
It looked like Andy had a question that might pertain to one of those. I don't know if you want to do that before I move on.
Yeah, sorry, I wasn't looking at the chat.
Yeah, sorry, Dave. Am I live? I don't know if I am. Can you hear me?
You are. Yes,
yeah.
We can hear you. See you.
It's just a question about dermatology, Dave, because I think there's been 3 previous never events, all related to wrong identification of the lesion to be removed. So do we know if the protocols that were in place were being followed and this is just a rogue event, or do we think that maybe some of those protocols had slipped given the difficulties with COVID, which I could well believe would be an issue?
The protocols weren't followed as they should have been.
Okay, thank you.
Okay, Thank you. So I'm just going to move on to the infection control metrics and the patient experience metrics. Just a bit of a reminder about the context. So Dave alluded to the fact that placing patients was difficult during Q4 because we were balancing patients' oxygen requirements against their infection prevention and control requirements, against specialty. So trying to place patients that was in the safest place for them. And it did mean we had to move more patients than we would normally have done. And much of that was driven by oxygen availability on each of the floors in the hospitals. So the first metric, the other thing I would say is Claire talked about the sickness rate having come down, but I can't emphasise to you how much pressure we were under. And the reason we're under significant workforce pressure was because of how surged our critical care unit was. So we were using around 60 whole-time equivalent nurses to support critical care, and that placed huge pressures on our wards and departments to support that and agency use. So although that sickness figure looks healthy, it also doesn't include the additional posts we needed for critical care, nor does it include staff that had to isolate because of COVID or were shielding because it's not classed as sickness. So the first area to draw your attention to is C. diff, and I think it's fair to say that C. diff has been a problem for us this year. We are working with community partners looking at antimicrobial stewardship. It looks as though some of our surrounding units aren't having the same problems as us. So we started early on in the year ribotyping every C. diff case we had. So looking at the genetic makeup of the virus to see whether the cases were linked. We have had some linked cases now. It looks as though there are 4 linked cases at the moment that have all come through ED over a 12 to 18 hour window. So we have concentrated on that focal point and put UV cleaning in place there. We've also done a series of deep cleans of toilets across the hospital since this became apparent as well. I think it's fair to say that the cleaning teams have suffered the same workforce losses that we have as well. And so they have been stretched as well, but we have got a clear programme in place now to meet the 2021 cleaning standards, and the deep cleaning programme will resume as well, which has also been difficult because we haven't had an empty ward to decant to. From a COVID perspective, you'll see that we did have quite a spike in February, and it's come down again in March, and that's a result of the rapid testing at the front door. So we know very early on the patient's COVID status. We continued throughout Q4 to have the outbreak meetings that are attended by NHS Improvement and Public Health England. We monitor regularly our compliance with patient swabbing, so patients should be swabbed on day 1, then day 3 to 5, and then day 7, so that we identify patients who have got COVID on admission. We're also looking at ventilation in clinical areas, compliance with cleaning, and staff uptake of vaccination and lateral flow, just to make sure that we're doing absolutely everything we can to minimise outbreaks in the hospital. And I can tell you that as of today, we haven't had a hospital onset case of COVID for 6 weeks. So that is a positive story. From a line-related septicemia, MRSA and MSSA, we have seen an increase in these. Much of this is linked to critical care, and you would have heard me mention that we had significant pressure there. So at times we were surged up to 300%, and that meant we had a high reliance on support staff that weren't familiar with the critical care environment. We have had infection control in there, doing a really detailed review, looking at practices within there. And there is some learning around sessional use of personal protective equipment and just ensuring that people do change the full set of PPE rather than gloves and aprons. So I think there is room for improvement, and we are seeing an improving picture. I think it's fair to say we have had more hospital acquired infection than I would have liked. We've done a lot of root cause analysis into these cases, and I think we've got some good learning from it that the team are out there and implementing, and the infection control team are now able to focus on ensuring that we've got a really strong campaign around the prevention of hospital acquired infections going forward. From a patient experience perspective, I just want to draw your attention to 2 metrics. So the complaints look as though they have significantly increased in Q4. In reality, over the year, we've had less complaints, but the problem is because we've had periods where the hospital hasn't been as full as normal, particularly during peak one, it is distorting that figure. The team continue to ensure that we respond to those complaints openly and transparently, and that we learn from them. And then the maternity FFT score you'll see is again an improving picture. So I'll hand back to Dave to just finish off.
Thanks, Julie. So I'll just go through a couple more. So the cardiac arrest rate, you'll see that that is red and elevated. We haven't found any significant concerns looking at those cardiac arrest calls. We've done some what's called antecedent reviews. That's where we look at triggering factors, and you'll see in the report that that's been mainly related to DNAR status or those aspects. I think I'm really mindful, and I would just highlight to board that cardiac arrest calls are sometimes used as a call for help, and we should recognise in this period of time we moved significant sick patients around the organisation, significant staff into different areas, and actually increasing our volume of calls for help would be entirely expected. I think that gives us a focus to perhaps look at some of that data if we can capture that, and explore actually why people are calling for help in that particular way. That's work to be developed. There is a slight spike in the cardiac arrest data, which has been a data anomaly. And you again notice that if you look back into the expanded table, we did put a stretch target in our cardiac arrest levels. What do I mean? Cardiac arrest standards. Thank you. And since then, we've seen that it's gone from green to red. And then finally, just moving on to HSMR, and I suspect this may stray a bit into the Learning from Deaths report, which comes next on the agenda. And I have put some additional detail into addendum that I've attached to the Learning from Deaths report to hopefully answer some of the questions that board have raised around this. So I would say that HSMR continues to be raised. To date, we found no evidence suggesting any systemic deterioration in quality or harm, and that's despite the very significant internal and external investigative work that we've done today. We continue to flag our HSMR and to question the CQC on this, and we ask them for any triangulation evidence that they have, but we have none as yet. I think what I would reflect on this is that there are three aspects, and again this is picked up in some of the other reports, three aspects with this HSMR investigation. There's something around the data quality, and that's the data quality that we're submitting as an organisation around our HES data. And again, in the various reports, there's been some description of the concerns we've had around the application of patient postcodes, which gives a deprivation code and impacts on our HSMR. There's also something around the diagnosis or the basket codes, which also is impacting on the HSMR. Having said all of that, it's not just data quality, because we have, with the investigative work, we have found a number of areas where we need to improve in our capturing. Some of that is around our coding, some of that is around our documentation, and particularly about how we write the diagnosis, which our coders then use. And of concern to me is if we're not describing what the diagnosis is, then I worry that we're not treating the right diagnosis. So there is work to do there, and we're working with the various teams as part of that. The second bit about the HSMR I'd put is something that we've discovered around our investigation of the deaths, and you remember that there is a concern about relying on HSMR or SHIMI as pure markers of quality, and the suggestion was to move to more a learning from deaths approach. Now, the learning from deaths is only as good as your investigation of those deaths. And what we found during the first wave of COVID was we put a really relatively small, tight group of reviewers to do our structured judgment case reviews, or SJCRs, and we found that we got much better consistency and quality from a smaller group, and that's enabled us to look back and to review our processes. And I think it would be fair to say that there's work to do there, and we need to put better consistency in there. Some of that is about training, some of that is about the challenge process, and there's a number of actions that we've put in to address that. We've started to develop a SJCR faculty to develop that expertise. We've strengthened the ME roles and the ME portfolio. We're putting some education aspects in there, and we've developed a much broader scrutiny panel for these SJCRs, again to give that challenge. And then the final thing I was going to mention around that is that we've also changed our data capture system to align with our DATEX system, so that then we've got all of our patient safety aspects in one electronic system, and we can then track the SJCRs, where they are on their completion date and what they show, along with any incidents, and use that as triangulation along with all of the other aspects that we use DATEX for. Last time, I'm just conscious that Neil isn't at board today, but last time Neil did ask me for a timeline of when I thought that the HSMR would be back to normal in effect, and we discussed that this work needs to take place, and I mentioned that I thought it would be a number of months. I've added to the addendum a Gantt chart to give board some flavour of that work and how it's progressing, and I'll continue to bring that back so board is sighted of the work that is undertaken and where it's going. And just finally, I'd say that one of the other aspects that was brought up I think by John McDonald last time was about getting some further external assurance around this, and just to let board know that we've now established links with the QE hospital at King's Lynn to share best practice and to try and help each other and to buddy because they have similar HSMR concerns that we do. So I might just stop there. Recognise I've said an awful lot of information along with Julie.
Thanks very much, Dave and Julie. We do have some questions. Graham.
Thanks, Claire. Thanks, Dave and Julie. I just wanted to pick up on the one because I heard quite a bit around oxygen and oxygen levels. We've been having quite a lot of discussions with our PFI provider on oxygen, and I just wanted, it would really help to understand it a little bit more. It can be offline, but to actually understand what our capacity is like in wards. Is that insufficient on an ongoing basis? Are there other issues around it? Because the more I can pick up about it, the more I'm able to actually use that within the discussions with them about how we formulate the strategy going forward. Because clearly not having sufficient oxygen supply is a major issue, and if we're having to move patients around as a consequence, that is not a good sign.
So do you want me to start on that? So this has been an absolute focus of the daily incident control team meeting, Graham. I think all of us would recognise that our knowledge of oxygen supply demand and the processes has dramatically improved during the course of COVID. I think I'd start off by saying King's Mill Hospital is in a much better starting position to most and certainly many other hospitals in terms of the oxygen supply. However, this has been an unprecedented time, and we've had very high volumes of patients on very high levels of oxygen. Now, one of the difficulties is it's really hard to be absolutely sure. So we've had very what we would describe as comfortable buffers in there, where we ensure that our patients are getting the right supply, but we have the safety margin. But despite those, we have come close to those buffers at a number of times and had to move these patients. And that's because the actual supply of the oxygen, as you go further up the towers, the pipes get smaller in diameter. and because our respiratory wards were towards the top of our towers, they had less supply because of that diameter. Now, there's a whole host of other things that we can pick up, and see Simon's come on who might want to come in. But does that answer it in the simplest of terms?
It does, yeah, and it also backs up what I was expecting to hear in terms of fourth floor, etc. Yeah.
We have been prioritised though, haven't we? So all of the kind of oxygen infrastructure equipment was placed under control of NHSE/I, and I know Ben and Paul were trying to get us equipment to increase that supply, and we have now been prioritised, is my understanding.
So things have moved on since this hospital was built. So I started saying we have a really very good supply. We've got 2 very large VIE tanks, or oxygen cold storage tanks. The recommendation is for that to be slightly altered, and so we are in the queue for BOC works to ensure that we meet those new requirements. I think we've developed a whole series of live and real-time monitoring systems. So we're using Nerve Centre, where the patients who are on oxygen are captured on Nerve Centre, and that gives us an overall picture. And so twice a day we get a report now about the amount of oxygen in demand in our organisation. But of course that's relatively recently. Prior to this, we had to have teams going around and capturing how many patients were on oxygen and record that. And of course there's been much national focus around this, but also recognition that giving too much oxygen to patients can be also harmful, and just ensuring that actually we've got the right patients on the right oxygen is another component of the balance.
Thanks very much.
Thank you.
Barbara, you wanted to come in?
Yes, thanks very much. So obviously it's disappointing to see so many red indicators in this quarter's soft, but I did want to thank you for your honesty and openness in explaining the context in which we've been, well, you and colleagues at the Trust have been working, because that I think helps us understand what's going on with these metrics, which at first pass obviously a bit disappointing. So thank you for that, and thank you to all the staff, because I'm sure that none of the staff want to be responsible for patients who've contracted COVID or have ended up with infections, and that must affect morale. So working in extraordinary times, a big thank you, whilst acknowledging, you know, it's not the sea of green we might want to see, but also thank you for providing us with the assurance that the indicators are now moving back in line with what we would expect to see. So long may that continue. Thank you.
Thanks, Barbara.
Thank you.
Andy, you had a comment as well.
Yeah, thanks. That's a really good update. I know we've had some conversations offline, Dave, but for me, for board, as a summary with the HSMR, there's something in it that's different. Part of that is COVID, because all other trusts have seen that both locally and regionally and nationally, but there's probably some specific things for us. You've got some ideas about what they might be that you're looking into. Things like the coding you'd see through our codes and the variance between expected and observed mortality. So I wonder if there's something about bringing something back to quality committee in due course, looking at some of those factors that will tell us how off we are, and would also give you an idea about when we may see the data returning back to normal. I think that might be helpful. And then the second thing is, obviously there's been a report from the National Medical Examiner in the last couple of weeks. I wonder if there's any lessons from that we might learn, and again that might be helpful to bring back to quality committee, and if relevant back to here.
Yeah, no, thank you. That's helpful, Andy. So the three areas of concern, or the hotspots, we have touched on these before, but certainly there's alcoholic liver disease, which continues to flag as an outlier, despite us doing work on that. And again, Andy reminds me that this has been an issue for many years at Sherwood Forest. I think both Barbara and I would be absolutely delighted if we could get more resource into our educational programs and our alcohol avoidance programs and all of those aspects. I think that would be a really powerful thing we do, and I've had some conversations with our gastroenterology team around this. The other hotspot or area of concern is our palliative care coding. And we are, I think, and again we've discussed this previously, we are the second lowest palliative care coding hospital in the country. We are significantly off the mean. That does skew our HSMR, and I know that if I put our palliative care coding back to the norm and run our HSMR data, then it comes back to pretty much where it should be. However, I've resisted doing that graph and showing it to you because actually I have found quite a lot of things that we need to address, and I don't want to put all of this just down to data manipulation and coding. And then the other area I might flag is around our learning disabilities. We know again from one of the national reports that patients who have COVID and learning disabilities have a 1.5 to 2 times additional mortality or risk of mortality. And this is again an area of focus that we're obviously taking very seriously. So happy to do that, Andy. I hope that answers some of those questions.
Thanks very much, Dave. And I think Dave and Julia, that was a very helpful session to explain some of the issues in the quarterly report and to provide that level of assurance. So thank you very much to both of you. I think we can move on now to Simon and take us through the timely care.
Thanks, Chair. Just a few things to pick up on. Emergency access ended the year at 94%. In March, we were ranked 10th in the NHS. I think this is over such a tumultuous year. I think those levels of performance are absolutely excellent, and I think that the organisation, because it's not just about ED, has done an incredible job. We spent 10 of the last 12 months in the top 10 lowest waiting times for emergency care. The most important bit of that, though, is it reduced crowding within the emergency department, and we obviously do see times of crowding, but on the whole that is under control and managed. And obviously we do very well. One of the best performers in the Midlands region on ambulance turnaround, which is a crucial safety statistic for patients in our community. That said, so I think looking back, really good. That said, we're incredibly busy again. So far during May, we are seeing similar patient numbers as to what we saw in spring 2019. And colleagues on the board will remember me talking a lot about growths in demand over that period. So that is worrying, and we need to keep a close eye on that with our partners across the system. In terms of what is happening. Some of that is to be expected because as restrictions reduce and the population is more active, accidents happen. And so we would expect some of that. We would also expect some patients to be coming back who were more cautious about coming to emergency departments during COVID spikes in terms of the risk of cross-infection. So I think we don't really know whether this is a temporary sort of increase or whether it's going to be an ongoing thing, and so we need to monitor that closely week on week, and colleagues on the board obviously get my weekly report around that. And then the final thing to say is that we expect a lot of the standards around emergency care to change during 21-22. I think there'll be a briefing coming to board on what we expect those changes to be. I don't know for certain, but the changes may take place ahead of this winter. Up until then, we will continue to use the 4-hour wait and crowding as an ambulance turnaround as our key measures of successful emergency care. But I think everyone, including our partners, have done a great job in terms of making sure patients get safe emergency access during the year.
Thank you very much,
Sorry, Claire. Sorry, I'll pause there on emergency care if anyone's got any questions.
Yeah, I don't think we've got any questions on emergency care if you wanted to go on to the next bit.
I'll carry on. On elective care, obviously, colleagues will be aware the waiting list has grown substantially over the past year. That growth has slowed somewhat in recent months. And a lot of our work is about for the next 6 months in H1, as Paul will come on to in planning later on in the private board section, is focused on activity levels and the expectations of what activity levels we need to get to. But importantly, making sure that that's done within clinical priority, and we have a robust process for time critical surgery that we've been using all the way through COVID. So those activity levels start off with 75% of 1920 activity in April, ranging to 85% in July. We expect April will finish at 90%. So we feel like we're in a good place around the activity levels, and that will start to erode the waiting list over time. I do expect that the length of wait for some patients who are more routine patients will continue to lengthen a little bit as we make sure that the sickest patients are treated first. But we are doing good levels of activity, notwithstanding the PPE that's required and the fact that we still require social distancing within the hospitals, and that does create at times a constraint on the number of patients you can treat face to face. I'll pause there on elective care.
Perhaps I can ask you a question. Is it possible to get a projection of when we think at the current levels of activity we will be able to eat in further to that waiting list, so that we can actually see the levels of progress?
Yeah, so in that is dependent on a number of variables, obviously, one being referrals into the organisation. So if referrals stay sort of where they are and we hit our activity levels, our waiting list will start to decline. But if that changes, it may be more challenging. Nationally, we're not being asked at the moment to necessarily focus on waiting list reduction. It's more about activity, but that will be in the soft for next year. And we will show a trajectory of what we think will happen to the waiting list with those risks identified around it. So hopefully that'll just be part of the normal reporting.
And will we be able to show timescales as well? So not only how we're eating into that backlog, but how long it's taking for people to remain on that waiting list. Because obviously, as you say, there's a number of different variables. People will be moved and reviewed according to the urgency of their cases. But are we able to give more information on that in due course?
Yeah, there's no reason we shouldn't be able to do that. Again, with risks that are on variables around that, but we should be able to be clear on what we expect the sort of what we will call the shape of the waiting list will be in terms of the length of patients that patients will experience. The other thing that we are about to do around this is another communication with patients around their position on the waiting list. And one of the things that I'm really challenging the team on that is to make sure that it's got an indicative weight.
Simon? On my screen, you've frozen.
I think he's frozen.
He has frozen. Right. Okay. Technology here. Richard?
I was going to say maybe we could move on to the.
Oh, Simon.
Back.
You're back. Yeah, sorry.
He might have momentarily gone off to do some system work that he was referencing earlier.
There's a question in the
throw me a bit off track. That
I
don't know whether Richard's comment or the Wi-Fi has thrown me more off track. So that was where we were around elective care. Am I okay to move on, Chair?
Can we take a question from Andy at this point, please?
Yeah.
Just a quick one, Simon. I mean, I think that's really good considering that we had a big wave 2 in Nottingham in the autumn. So I think we were disproportionately affected compared to other places. Do we know what scale of risk we're carrying around some of the planning guidance on health inequalities and catching back up in terms of health inequalities, not just in terms of chronology? Does that give us a better position at Sherwood? Does it make it harder for us, or is it neutral? Do you have a feel for that?
Only at a high level, Andy, and I think to a certain extent it makes it a little bit harder for us at Sherwood. But in future softs, I can give a bit more detail on where we might be going with some of that work. So I think it's quite early around that work in terms of the planning guidance. And clearly the work with Nottingham around this will be incredibly important as well in terms of how we're working together across the system to deliver some of this.
Okay, thanks very much. Do you want to move on to the next piece then, please, Simon?
Finally, around cancer. So we've been saying we'll be in a range of 70 to 75% on the 62-day. We were in that range during February. We're slightly outside it across the system. We're at 68.5% when joining Nottingham and ourselves together, and that's the way we need to look at this. As I've talked before, 50% of our patients go between both organisations with On the Cancer Pathway. Our backlog is today is just over 100 patients, and obviously by March 22, the objective is for that to be at 45 patients. We're bringing an improvement plan to board next month that will start to describe how we will do some of those things, both internally within Sherwood, but also working with Nottingham to make sure that our bit isn't okay. Yeah, the Nottingham bit is more challenged. The average weights and the 85th percentile weights for cancer care remain the same and are relatively flat. So that I think that's positive, and it's very positive to see we're at 79% on the time to diagnosis. The one thing I would say about that though is that obviously there's a large proportion of patients within that FDS, as they call it, the diagnosis thing, who haven't got cancer, who get a pretty quick answer to the fact that they haven't got cancer, and our concern remains in that diagnostic phase for those patients who have got cancer, and that's the bit that we obviously need to improve. Lower GI is absolutely critical within that. Lower GI represents a substantial amount of our backlog, and our plans to sort of redesign that pathway will be in that improvement plan next month. Although nationally we don't do too badly when compared to other organisations, because lower GI is a really challenged sort of area nationally, but I still think there's work that we can do to improve on that.
Okay, thank you.
Chair.
Thanks very much, Simon. Very good report, and I don't think we've got any other questions for you, but we can move on now to the finance.
Thanks,
Paul.
Yeah, thank you. So again, year-end performance confirmation. So our final year-end outturn is £5.5 million deficit, and that's as we forecast, and is actually a £3.7 million better than the plan that we submitted back in October. And that's due to central funding receipts in respect of the increased annual leave accrual due to staff not being able to take their full entitlement during the year, and also our lost opportunities to gather other income sources from outside the NHS. Our total expenditure for the year was 428 million. That's 34 million more than we thought that it would be when we planned. That's made up of 22 million, which was in direct response to the COVID-19 pandemic, £8 million, which was undertaken in delivery of the COVID vaccination programme, and then 2 central adjustments that were added at the back end of March with notional income and expenditure to recognise that there's been across the NHS increased employer pension contributions and also a large amount of PPE and equipment were actually provided from central stocks. So those adjustments have been made to each provider final outturns. Two final points on revenue. The draft annual accounts have been submitted for audit and were subject to a review by the audit committee in the month, and the accounting final outturn includes an impairment of asset value. So in our final accounts, we have to record any fluctuations in the value of assets in the year, and those fluctuations aren't recorded against our in-year monitored performance. So therefore I wouldn't normally report them, and certainly NHSEI don't monitor our delivery of that. But in our accounts you will see an impairment, therefore a further charge of £5.5 million in the accounts when they come for approval by the board in June. And then secondly, the plan that has been submitted for that was submitted for 2021 was an ICS plan in total, and across the ICS, including our outturn, that is reporting a £3.6 million surplus, and that was following receipt of £10.3 million from central funds to recognise the improvements that had been made during the last 6 months of the year. Just lastly, in respect of capital, our capital expenditure was also as forecast, and although we're reporting it's £7.8 million in excess of the original plan, that is because we were in receipt of additional resources provided in year for urgent and critical projects that have been delivered. Happy to take any questions.
Thank you, Paul. I don't have any questions in the chat box for you, so thank you very much for the report.
Thank you.
Excellent. Okay, Richard, I hand back over to you now. Do you want to pick up on this?
Thank you. So the quarterly update of our board assurance framework last came to board, I think it was February. You can see in the report the committees that sit below the board that have reviewed the risks over the last couple of months. The Quality Committee, the People, Culture and Improvement Committee, Finance Committee and the Risk Committee has met 3 times over the last quarter. You can see in the report in blue the items that have been removed or amended, and in red, as always, you can see the areas where we have made some changes. I'll draw attention to Principal Risk 3, which is critical shortage of workforce capacity and capability, where the likelihood has been downgraded from a 5, which is very likely, to a 4, which is somewhat likely. That changed the overall risk rating from a 20 to 16, which is significant. That feels more appropriate to me, and I think ties into the conversations that we've been having today. And then there are some other amendments through the report. We have 3 risks: Principal Risk 1, 2 and 4, where the risk overall remains significant, as well as Principal Risk 3. So we're asked to review the report in light of the proposed changes that have been through the lead committees, as I've discussed, to consider the implications of current risk ratings being above tolerable levels. That's been in the case now for a number of years, to agree any further changes, and then to approve the BAF subject to any further changes identified. Very happy to take any questions.
Okay, Shirley.
Yeah, I think as a board we really need to look at the BAF risks that are above their tolerable. So they have been above tolerable now for a year. Now, obviously that was to take account of COVID. So I think we need, as a board and probably as risk committee, to review those now and see to bring them back within their tolerable ratings. So that's what I would advise, Claire, and we can take it back to risk committee.
Okay. Dave, do you want to come in?
The only comment I was going to make, well, I think absolutely it is time to review all of this. We were intermittently throughout the various waves, we've replaced almost the risk of being overwhelmed with COVID to the risk of being overwhelmed with these backlogs or this these patients who we hadn't seen during the period of time. And I think now we're getting a much better handle on that, as Simon's described. And so I think it is a timely moment to do that.
Okay, Richard.
Agree with your point, Shirley. Just to understand the governance, I thought it wasn't the role of risk committee to review the risks. I thought it was the individual committees, but am I wrong?
No, you're right. It is the individual committees, but as risk committee, I think we should make the recommendation that the committees review these and try to bring them back within the tolerable levels.
Okay. So could we
have an initial discussion at risk committee?
Perfect. If we could just, can't picture in my head when the next committee timelines are, but if we could take an action here, we will have that conversation in risk committee. But if there are any other committees in advanced finance, quality people, etc., please proceed as Shirley described.
Okay. Graham, do you want to come in?
Oh, thanks, Claire. Only in the sense that I agree with Shirley. The more we can have a look at the tolerable level, because ultimately, if we're running for a long period of time where our risk profile is significantly higher than the tolerable level, then that equals stress. So it can't be sustained in that way. So we've got to properly understand both our tolerable levels and the overall risk level. Otherwise, we're kind of showing ourselves in a much more stressed environment than perhaps we want to be. Although recognising certainly for the last 12 months, I think that was the case. And I suspect it's still going to be the case for much of the next year plus, because as we go through the restoration. But it's just building that in, and for us as a board, as well as each of the committees, to recognise the importance of the difference between those two measures. But so I totally back up the approach that Shirley's done and what you recommended, Richard.
When is the next risk committee?
It's either next week or the following week. Just 1 second. I think it might be next week.
Okay.
It is. It's next Tuesday.
Next Tuesday. Tuesday the 11th.
Right. Okay. And quality meets next week as well, so there's an opportunity for two committees to look at this. Okay. Are we happy to proceed on that basis then? Yeah.
Shirley, sorry, Chair.
Yeah, sure.
So again, go back to a governance perspective. We've got the recommendation ask that the committees look at it. Are we able to recommend that the committees downgrade risks where appropriate, or is that jumping the gun?
No, I think we can do that, but we need to have the conversation in risk committee first with all the right people around the table, don't we? Because the leads for the risks are in the risk committee, so we can have that discussion, and then the lead officer can take it back to the committee and discuss with the NEDs.
Perfect.
And this will then come back to the June board, will it?
I think it goes back quarterly, Claire.
Quarterly, okay.
So August, I think.
August, okay. All right, thank you very much for that.
Just picking up on that, so we've got the governance correct. I mean, if we're not coming back till August on that, I think we still need to approve the BAF as we've got it now, and recognise we're going into a phase of in-depth review of it over the next quarter as well.
So are we happy with to approve the BAF as stand on the basis that it will be reviewed through the committees? I'm assuming there's no dissenters, so I take that as approval. Okay, thank you. Right, we are moving on now to the Learning from Deaths quarterly report. So hand over to Dave, please.
Thank you, Chair. Just conscious that we've discussed quite a lot of what's in this report when we were giving the update to the SOF. So I just summarise perhaps in terms of the HSMR and the learning from deaths are clearly intertwined. So in summary, the HSMR is relatively stable. It's not deteriorating. We're still unclear of an exact cause and what that means. There are three areas we're investigating: something around our data consistency, something around our review process and our learning, and then specific areas that Andy and I were discussing earlier. What I would just draw board's attention to is perhaps the two graphs on page 4, which is figure 3.2, the HSMR, where it shows that fairly consistent period, and then towards the end as we're going into wave 3. If you compare that with the line underneath where our other organisations seem to be steadily increasing. So again, difficult to be clear of that, but we quite like the stability aspects. And then the graph below 3.3, what we've done there is we've plotted pretty much the raw data across a much longer time period, just to see actually whether this is normal variation or if this is something significant. And again, whilst we can see the peaks and the troughs there associated with the COVID waves, it's been a fairly static process. I would also just note that the SHMI, the standardised hospital mortality, has been consistently within its target range. And I was looking at our latest SHMI data yesterday, recognising it is 5 months in arrears, but that is wave 2, and I think our SHMI is running at 96 on that. So some level of assurance there, notwithstanding what we said before. In terms of the learning from death, I think the actions are in there, the report's in there. I think, well, I hope board would take this as a strong commitment to improve the consistency of the data and the process that we're trying to do, and therefore really get some learning from that. I just mention that we've also been looking at alternative providers of some of our external mortality data, and again there's some detail in the paper there, and just concerning that that comes back to the data manipulation that we've talked about perhaps before, but I'd very welcome comments from Andy about all of that. So I'll stop there and take questions.
Thank you. I don't have any questions in the comment box at the moment, but I do know that you've had an opportunity to talk to both myself and Barbara and Andy about this, and to have that discussion offline. So I think that's probably helped significantly to provide that level of reassurance, Dave. Thank you for that. Okay, so moving on to assured from the report, and we're moving on now to the application of the Trust Seal quarterly report. So Shirley.
This is just a verbal update, Claire. There have been no uses of the Trust Seal that haven't previously been reported to board, so it's just part of our quarterly work plan that we just formally record that.
That's fine, thank you. I think we're sticking with you now, and moving on to NHSI self-certification.
Yeah, this is our annual self-certification to say that we are compliant with our FT licence. This has been through the exec committee, who have all recommended that we are compliant with all our requirements on the General Condition 6, FT4, Service Condition 7 and the Commissioner requested services. We have added some narrative to reflect the impact of COVID, particularly around the governance systems and the governor training requirements, but we don't think that leads to any unconfirmed responses. So it's here for board approval, and if we get approval, then it's here for signature for you and Richard to sign. We no longer have to submit this to NHSI, we just have to publish it on our website.
Okay, right. Well, again, no dissenters registering, so I think we can take that as approval. Thank you, Shirley.
Thank you.
Excellent. Now we've withdrawn the estate strategy document that was on the agenda. That's going to have a little bit more piece of work on it, isn't it, Graham, before it comes back to us?
It is, yeah. Yes, and look forward to seeing you back in June.
Excellent. Okay, thank you very much for that. So moving straight to you in terms of reports from the subcommittees and audit and assurance.
Thanks, Claire, and I'll take the following reports as being read, but just highlighting a few bits. First thing is we heard on the draft Head of Internal Audit opinion for last year. We're heading in the right direction, I'm pleased to say, but due to COVID and due to other reasons, we are behind with some of the work plan, and it's really important that those outstanding internal audit works are completed ahead of the next audit meeting, so that we can get hopefully that full significant assurance from 360. So it's just really emphasise that the importance of the work and support to 360 to deliver those. We also approved the internal audit plan for this current year. That's kept flexible because we recognise that there might be some changes as the year progresses, so we'll work on that closely. We also received 2 limited assurance opinions, which I never have a problem with limited assurance opinions. It's all about how we actually take them forward. And I think these were very useful. It highlighted with both the NHIS governance and interface and rapid response liaison psychiatry service that we maybe don't have quite the grip and control that we would normally have, where we're working with services which go across organisations, whether we're using them or whether we're sharing those with others. And it highlighted quite a lot of general issues that we need to get tighter on, in particularly around that grip and control and governance. So it's what we concluded from it, apart from the actions being implemented for those particular reports, but it will be a useful exercise to better understand where else we have these kind of services and what position we're in on them. So we'll take a little bit more of a look at that through audit committee going forward. Then the only other thing to highlight, which was the COVID-19 audit. I think we were one of 13 providers that Deloitte's reviewed. Really pleased to say, yes, there were 1 or 2 little bits because of the speed of how we had to put in the requests for monies. But generally speaking, we got a reasonably clean bill of health on that process. All of the findings that came out of that have been provided for as well in the accounts. So I think there have been a lot of questions during the course of this year about, are we making the right claims? I think this helped give us quite a lot of assurance that our finance team have done an excellent job throughout the process. They were the main things I wanted to comment on in terms of the actual last meeting. Also attached is the Audit and Assurance Committee annual report. Again, I'll take that as read. I'm quite happy that we've delivered all the things we're expected to during the year. I think we will put a little bit of focus during this course of the next year on really making sure we implement our recommendations from internal and external audit on a timely basis, and getting that triangulation with the other committees on an ongoing basis, I think, is really important too. And then finally, I think it's around us looking increasingly at the system side and the ICS and the ICP and where we get assurances from there, and make sure everything's joined up in the right way. So be an interesting year. But
okay.
Happy to take questions.
Thank you, Graham. I think that's very helpful. I don't have any questions in the comment box there at the moment. So perhaps we'll say thank you very much. And
that's all right. You've got me again now.
We have. I was just going to say, are you going to do Neil's report in his absence?
Yeah, highlighting a couple of bits, saying we had a lot of discussion around the 2021-22 plan. I think we're moving forward with it reasonably well. We will have a lot more discussion about that in the private board, so I won't say anything more on that at this stage. We had a look at the FIT plans for this coming year as well, which are highlighting that about 102% of our initial target, but that target could be a bit of a moving feast. We'll have to see how it goes, but there's quite a lot more work necessary to go into that to get the detail behind it, and we'll take a closer look at that in the next period, in the next meeting. Also, just to highlight on the PFI contract, that's moving forward. The important thing is that performance isn't perfect by any means, but it is. When you read below the threshold, it sounds as though that's bad. Actually, that's good, because the threshold is where performance goes into default scenarios if they're above it. So at least we're in that particular phase. And then the final bit I just really wanted to comment on, going back to what Paul detailed, was the really good performance in what's been a challenging year on the financial side, and that we've met the figures we were expected to do. In fact, we've exceeded them with some help, I know, but it shows the level of work that's gone in from the finance team and from the rest of the trust in making sure we keep a control on things in what's been a challenging period. Similarly on this, there's also the annual report. I haven't got anything particular to pull out from that, but happy to take any questions.
Right, okay. I'm not seeing again any questions at the moment. Clearly very happy with everything that we've seen and been reported. You've done a good job on Neil's behalf, Graham.
That is clear.
Okay, thank you. Can now unfortunately Manjeet has not been able to attend at the last minute today, and she is chair of People, Culture and Improvement Committee, and so I've asked Andy, who was at the committee for the first time, if he would like to report back to the board on her behalf.
Thank you, Claire. Off the bench, I'll try and do my best and do justice to Manjeet. So the People and Culture Committee agreed new terms of reference. It discussed the annual report, which was approved, with a comment about how we add more about the impact of leadership development in the trust. The annual review of the committee was agreed. It's fulfilling its functions. We received a 360-degree audit of pre-employment checks, which gave significant assurance, which was discussed and well received. We discussed the BAF, and that led to a conversation about how we get more visibility of assurance around transformation, innovation decisions, how we decide which areas we're going to invest our effort and time in. And Emma is going to pick that up, not necessarily through the BAF, but I think some of those discussions need to be more visible. We had a good discussion about the People and Culture Strategy, which is a very good document. We felt maybe that will benefit by a summary that sort of tells us what the trust would look like in 12 months' time, what might we expect to see shift. And then there were some good discussions around safe staffing. We received a report from the volunteers, and the committee expressed its thanks back to Tracy for the significant contribution they continue to make to life at Sherwood. We had a review of the staff survey, and again, brilliant results. And the committee expressed its thanks to all the staff at Sherwood for their ongoing efforts through what's been a very difficult year. I think they were the main highlights, Claire, but I'm happy to highlight any that you've picked up that I've forgotten.
No, I think you've done a very good job. You know, been very good deputy there, Andy, in those circumstances. So much so that there doesn't appear to be any questions either. So thank you for that. Can I move on then to Tim? Tim, you're going to present Charitable Funds Committee for us.
Thank you, Claire. Thank you, everybody. As always, I'll take it that the documentation's been read. There are just a couple of things I'd like to bring to the attention. One is that the Newark one-stop breast clinic is a bit challenging at the moment for it to be fully operational, and the only reason I'm really bringing it to your attention is that as the board of directors, we're all the trustees for the charity, that there are actions in place to get this resolved, but I just felt it important that I escalate that to you as from you being the role of trustees. The end of life project is progressing, as you're aware, we highlighted earlier, but I just wanted to bring to your attention that Amazon locally, who are literally in a stone's throw of Kings Mill, have made a donation, and also Sherwood Forest Hospitals are now on the Amazon list of charities of which people can purchase their products when they do for Amazon. If they click on that smiley link and name SFH, we will receive some contribution towards that. And that we are developing further engagement and links with them. Tracy Brassington and her team are working on that. We did the annual health check, and we ensured that all the actions, which there were only a couple from the previous year, have been implemented and embedded. We have no concerns going forward, ongoing. And the final thing is that the annual report was discussed, of which you have for your views, and I'm happy to take any clarification. The one thing I'd like to highlight that's in the annual report, what it does do is it gives a bit more depth and breadth into the amount of work that Tracy Brassington and her team and all our volunteers and the Daffodil Cafe, the amount of work and energy they put in to enable us to receive the support of charitable funds. One thing I'd like to say is I think it was Tracy Brassington's little project that she brought forward was Dragon's Den, that's been hugely successful. And one of the benefits from that Dragon's Den success we heard about earlier, which was part of our patient story, where the Rita project was supported through charitable funds. So Claire, I'm happy to take any points for clarification, but I hope that gives you a positive overview of the work of the Charitable Funds Committee.
That's excellent. Thanks very much, Tim. And what a wonderful job Tracy, her team, and all of our volunteers have been doing. And one of the things that I had the pleasure of doing, becoming chair, is the opportunity to sign all of the letters that go out from the Trust to thank people for the donations that they make to the Trust and to charitable funds. So it really is a pleasure from that. Can I just ask you, Tim, I noticed that you discussed the review of the fund structure. Have you now agreed on changes that will make it easier to be able to use the funds where you need to?
Hang on. Poor Ted lost you then, Claire. No, yes, we have. There are some areas that were, as you're aware from your previous experience, that were a little bit slow moving or small pockets, but also there are some things we're having to introduce as well. But no, hopefully it will. But the other thing as well is I think we've got members of staff that are being more proactive with the fund managers to enable us to utilise some of those funds that are held on behalf of the different divisions.
That's helpful. Thanks very much, Tim. And I don't have any other questions here for you, so thank you. We're now going on to the outstanding service and Bright Sparks. So Richard, are you going to introduce this?
Yes, so it's exactly as you've said, Claire. This is one of the videos presentations in a series of outstanding services. We've paused them for a while. To be honest, I wasn't at the board last time, so I'm not sure if we saw one last month. But this is about Bright Sparks. I haven't seen it, so I'm very much looking forward to seeing it. Are we able to load it? Thank you. I think it's muted. Is it possible to unmute it?
Robin, try the space bar.
Restart that. I don't know what it is. Hang on a second.
Hello, my name is Barbara Uchik. I'm the Quality Improvement Officer in the Service Improvement Team. The Bright Spark project is a project where we ask staff to submit their little ideas they've got about improving something in the area where they work. There could be little projects, not time-consuming projects, where we can help you, we can assist you, guide you in improving something in your area as well. We've had quite recently an idea about a QR code display board, so where all the leaflets, the patient information leaflets, could be displayed as a QR code, and the QR code will take you to the information leaflet instead of wasting paper. An example of in the pediatrics, again on the pediatric ward, about when little patients come in to change into like a superhero PJs, so they can wear that and to redecorate the pediatric ward that could be an improvement as well. How we do it, we are displaying posters, the Bright Sparks posters around the trust, and we are distributing the little postcards, the Bright Spark postcards. It's got the address, so you just pop your ID on. It could be anonymous, but that way we'll not be able to find out who submitted, so we ask you to pop your name, your contact details on it, and then just pop it in the post, and it will arrive in the internal post. You can also submit it by email. The ultimate goal will be to encourage staff to come out with the Bright Spark IDs and to improve the areas they're working in, and improve patient experience as well. So by day spot, they work in the areas day in and day out, so they can come out with a Bright Spark ID to improve it.
Very good.
Thank you to Barbara and the team there. People will remember the aim of the video is to draw attention to some of the services, or in this case initiatives, that many of us will be inevitably unaware of given an organisation of our size. I thought that was really interesting. It was great to hear the initiative about the QR codes for patient leaflets. Big fan of QR codes, and I hope we're able to implement that. And I'll just earlier on in the public board meeting, I think I was talking about sort of the system and some of the behaviours that are required for whether it's within an organisation or across the system for things to work. And one of that bit was about sort of including colleagues, and the second one from memory was about people. If we're delivering a change, the change needs to be driven by people, need to be there for the inception of that change. And I think this is a good example of it, as Barbara was describing, trying to engage with the wider organisation. There's lots of great ideas out there, making the mechanism between people identifying a change and delivering the change to be as easy as possible. So hopefully that was interesting for people.
That was very good, an excellent initiative, and we look forward to seeing lots of bright ideas and bright sparks coming through. Okay, thank you. Lorna, communications to the wider organisation. So obviously, I'd expect us to be covering something about our discussions on the staff survey, the AHP discussion report that we had, specifically around the investment areas and our patient story. What else did you have in mind as well, Lorna?
Yeah, I thought it might be worth talking a little bit stuff around the plans around Newark, which we mentioned briefly. I also thought we should try and socialise the partnership agreement behaviours a little bit more across the organisation. We need to do something more widely anyway around the violence and aggression programme of work, just to make sure that's being shared across the organisation, and also the increased nursing and midwifery establishment figures.
Excellent, great.
Oh, and a thank you to our volunteers as well, and those who supported us for the last year.
That would be very good, and also just a reminder probably on some of the work that is taking place with the charities through charitable funds too.
Yes.
Okay. Great. Thank you very much. So I think I don't know if there's any other business. I've not been notified of any other business. So I'd like to declare the meeting closed, and before Shirley tells me off, I have to read the resolution to move to the closed session of the meeting. So in accordance with section 1, part 2 of the Public Bodies Admissions to Meetings Act 1960, members of the board are invited to resolve that representatives of the press and other members of the public be excluded from the remainder of this meeting, having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest. And I assume we have approval from that. The next meeting will take place on the 3rd of June. Shirley, is there anything else?
Just thumbs up.
Great, excellent, thank you. Have we been notified of any? We haven't been notified of anything else in relation to any other business or from members of the public, and I'd like to declare the meeting closed and look forward to seeing you all later for our board, but also to members of the public on the 3rd of June. Thank you.
Thanks, Chair.
Thank you.
Thank you. Thank you, Chair.
Thank you.